ये सोचेंगे इसका भी आइडिया।
हाँ
और सीएमई और उसके खाने पीने का तो मजा खत्म ही कर दिया तुमने।
अपना नहीं कर दिया।
Hello, good evening.
Good evening, Anurag. How are you?
Good evening, sir. How are you?
Good, good.
डॉक्टर अनुराग नमस्कार सर।
जो ज्वाइन करता जाए उसके घर में 4-4 समोसे भिजवाते जाओ।
मेरे यहाँ तक ठंडे हो जाएंगे बस।
तो तुम तो प्रेसिडेंट हो भैया, तुम्हें समोसे की जरूरत थोड़ी ना है। Only delegates like us will get the samosas.
Do we start now, sir?
No, let's wait.
5 minutes, 5 minutes, 5 minutes.
Yeah.
नमस्कार डॉक्टर भटनागर सर।
वाह डॉक्टर पंकज, आपके पीछे जो मोर पंखी है ना, बहुत बढ़िया है। आप फोटो खींच के देखिए।
ऐसा लगता है जो मेरे पास सर पे ही मोर है।
कृष्ण भगवान लग रहे हैं आप बिल्कुल।
टकला पर ज्यादा चमकता है ना। शाइनिंग लगता है एकदम टकाल के तरह लगता है।
डॉक्टर अरुण गुप्ता का कुछ आइडिया?
अब जा रही है
डॉक्टर अरुण का। हाँ, he has joined. Sir has joined.
हेलो
हेलो
हेलो।
ओके।
आवाज तो जा रही है।
अरुण, गुड इवनिंग।
हाय, गुड इवनिंग। आवाज आ रही है?
अब बिल्कुल आ रही है, लाउड एंड क्लियर।
आ रही फिर ठीक है। ओके, कैसे भैया?
बस ठीक हूँ, आप कैसे हो? ठीक है।
मैंने आपको उस दिन कॉल किया था, 1-2 बार आपका फोन मिला नहीं।
हाँ, मैंने आपको कनेक्ट करना चाहा था, कांग्रेचुलेट करने को।
हाँ
वो सूखा नहीं, सूखा कांग्रेचुलेशन नहीं।
नहीं, उसके बाद मैंने मिलाया था आपको।
अच्छा।
मैंने चलो उसके आपका बाय चांस बात नहीं हुई, आपका बिजी हो
हाँ,
गया, मुझे याद नहीं आ रहा।
चलो, दिस इज अ गुड टाइम टू टॉक टू यू, सी यू फेस टू फेस। वेरी नाइस।
कैसे हैं
डॉक्टर सर? नमस्ते सर।
डॉक्टर क्या हाल?
वेलकम सर। बढ़िया।
आवाज है क्लियर आ रही है?
डॉक्टर अरुण वेलकम।
हाँ जी वेलकम जी। ललचंदानी साहब कहाँ छुपे हो, दिख नहीं रहे?
आपके चरणों में है, नीचे तो देखो।
नेता लोग ना, हमें तो डायलॉग नेता वाले मारेंगे हमेशा। कहाँ गया?
सर आम आदमी पार्टी के सशक्त कार्यकर्ता हैं, नेता नहीं है।
ये तो पक्का। अब तो कमर कस लो। अब डीएमए डीएमसी खत्म हो गई, आम आदमी पार्टी में लग जाओ 1.5 साल के लिए। कहीं से इसमें वो इतने सारे देखने वाला ऑप्शन कहाँ से होता है? सारे विंडो दिख जाते हैं की बात। मुझे खुद भी नहीं आता।
स्टार्ट कर।
जब करना।
डॉक्टर पंकज, शुड वी स्टार्ट?
पे वो वाला विंडो कहाँ होता है जिससे बहुत सारे लोग देख सकते हैं सर? कैसे होता है?
गैलरी व्यू में आ सकते हैं।
डॉक्टर मुकेश, शुड वी स्टार्ट?
हाँ मैम, कर सकते हैं। अभी थोड़े से 5 मिनट बाद ज्वाइन कर ले लोग थोड़े से और। डॉक्टर नरेश सर, डॉक्टर चावला सर, नमस्कार सर।
नमस्कार भी, नमस्कार।
नमस्ते
मैडम, नमस्कार। I am so happy that everything is starting well in time. Congratulations to IMA Dwarka and you enthusiastic workers that you are doing a very good job. Yeah, good CM. I must say this time to start हो गई है। नमस्कार सर, नमस्कार पीके।
नमस्कार सर।
नमस्कार सर, नमस्कार।
अरे बुर्का तो हटा लो। अभी
मुकेश नमस्कार भाई।
सर नमस्कार।
आपको हटा लो सर।
बुरा
सर नमस्ते
बता
सर।
नहीं नमस्कार भैया।
दो।
घर पे है सर।
नमस्कार सर।
स्टार्ट कर लेते मैम, फिर उसके बाद
हाय मुकेश।
सर नमस्कार। डॉक्टर सचदेवा नमस्ते सर।
नमस्कार।
सचदेवा सर नमस्कार।
पुष्पिंदर सर नमस्कार।
गुड
नमस्कार।
इवनिंग सर।
He's left.
डॉक्टर अमित सर।
भाई नमस्कार भैया। संजय भाई क्या हाल है? I'm so glad यार।
सर क्या हाल चाल?
आपका अब लग रहा है।
Yeah, so glad.
डॉक्टर चावला सर गुड इवनिंग।
नमस्कार सर मुकेश। I received your message and I sent a reply immediately. Thank you, so nice of you.
अच्छा थैंक यू सर।
तो
स्टार्ट करते हैं।
ये टेंशन खत्म हो गई ना। तो मनुष्य में मिलियन से
हेलो
अपनी सीमा टाइम
हेलो
स्टार्ट
डॉक्टर
करो।
चौहान।
नमस्कार सर।
डॉक्टर चौहान।
डॉक्टर बनर्जी वेलकम।
डॉक्टर बनर्जी सर, welcome sir. So good evening friends, colleagues and senior members of IMA Dwarka and Delhi. आप सभी को नमस्कार और उम्मीद करती हूँ कि आप सभी अपने परिवार के साथ स्वस्थ होंगे, क्योंकि आप स्वस्थ रहेंगे तभी आपके पेशेंट्स भी स्वस्थ रहेंगे। Today we are here for another academic feast with the galaxy of eminent speakers. लेकिन शुरुआत करने से पहले कुछ शब्द कहना चाहूंगी। एक वीडियो मैंने शेयर भी किया था, वो सभी कोरोना वॉरियर्स के लिए, हम सभी के लिए।
है मैं हेलो हो चुकी मैं कह रहा हूँ सबसे हेलो हो चुकी है।
All should mute their mic.
सबके दीपमाला सबके बाकी सबके म्यूट कर दो, वहीं से कर दो।
So
अपने अलावा सबके म्यूट कर दो आप वहीं से ना, जहाँ से जो एडमिन हो रहा।
So in the beginning, just starting with a few lines for the corona warriors. We all are warriors, और we know that time is bad, लेकिन हम सभी मिलकर इसको पार कर लेंगे। तो कुछ शब्द हम सभी के लिए हैं। ये मत पूछो खुदा से मेरी मुश्किलें बड़ी हैं, ये मत पूछो खुदा से मेरी मुश्किलें बड़ी हैं, ये मुश्किलों से कह दो कि मेरा खुदा बड़ा है। आती है आंधियां तो कर उनका खैर मकदम, आती है आंधियां तो कर उनका खैर मकदम, तूफान से ही तो लड़ने खुदा ने तुझे गढ़ा है। So we are all ready here to fight the war against the corona. Last Sunday we started, IMA Dwarka has started a new initiative of conducting eCMEs, MIdcon. So this is our second CME. The last one was with the Venkateshwar Hospital, and today's webinar is in association with Manipal Hospital. Manipal Hospital is one of the most premier hospital in Delhi. The hospital is known for its quality of consultant and excellent patient care. We'd like to have more association with Manipal Hospital, both offline and as well as online. So now, before starting, I'd like to welcome our Honorary Secretary of IMA Dwarka, Dr. Preetam Pankaj, to welcome all the delegates.
Thank you, ma'am. Thank you. Good evening, all. I am welcoming all of you in behalf of IMA Dwarka. I am welcoming Dr. Arun Gupta sir. Dr. Arun Gupta sir is well-known doctor in Delhi. He is leading from the front for us. He is president of Delhi Medical Council, and we are privileged to have president as well as vice president of Delhi Medical Council today. Dr. Naresh Chawla is vice president of DMC. Welcome, sir. Welcome to the interactive session. Great, sir. Thank you, sir, for welcome for coming into IMA Dwarka forum whenever you get invitation, and oblige us, honor us for your presence. Thank you, sir. And I'm welcoming all the great speakers who are having their different aura in their field. And I'm welcoming all the speakers. I'm welcoming Dr. Prakash Lal Chandani, sir, who is Senior Vice President of DMA. I'm welcoming our all past President IMA Dwarka, Dr. Deepmala Lal Chandani, ma'am, Dr. Rajiv Bhatnagar, sir, Dr. Kiran Shankar Banerjee, sir, all are here, and I'm sure there will be great discussion, great CME, as usual. Dwarka is known for. And now I'm requesting our president to speak and address the session. Thank you. Thank you, ma'am.
Thank you, Dr. Preetam Pankaj.
Thank you, Dr.
Now
Preetam.
I request Dr. Mukesh Verma, Dynamic President of IMS Dwarka. Dr. Mukesh, please, few words from your side.
मैडम नमस्कार और सभी लोगों को मेरा नमस्ते. I welcome you all. I formally welcome Dr. Anurag Saxena, Dr. Arun Gupta sir, Dr. Ashish Agarwal, Dr. Kiran Shankar Banerjee sir, Dr. MP Chaurasia, Dr. PK Gupta, Dr. PK Sachdeva sir, Dr. Deepmala Lal Chandani, Dr. Naresh Chawla sir, Dr. Prakash Lal Chandani, Dr. Preetam Pankaj, Dr. Yugal Mishra sir, Dr. Rajiv Bhatnagar, all the dignitaries who have joined here for today's webinar. And I also welcome all the delegates who have, despite busy schedule and a great Sunday evening, they have spared time for this webinar. So it's a great privilege to welcome you all to the second edition of the learning series, the academic learning series. We have named it the IMIDcon. The first edition was held last Sunday, and it was also a huge success. And we at IMA Dwarka are constantly trying to do academic programs along with other social and cultural activities throughout the year. But this year has been challenging because of the pandemic. But over the last few months, we have adapted ourselves to this new normal, and we are trying to do not just digital CMEs, but we have it's a happy moment for me to announce that we will be conducting our annual conference soon, and it will not be online, it will be an offline conference as usual with all the social gathering. We are planning to do it in the around first to second week of January near the Makar Sankranti, and I'm happy. So we are planning to welcome 2021 in a truly IMA Dwarka style. And I again welcome, I'm privileged to welcome all the dignitaries who have joined here, especially our guest of honors, Dr. Arun Gupta sir and Dr. Naresh Chawla. So without wasting much time, I would request Dr. Deepmala to start with the day's proceeding and the others, the event, the flow of the event as we have decided.
Thank you, Dr. Mukesh. We have with us Senior Vice President DMA, Dr. Prakash Lal Chandani, who is the ex-president of IMA Dwarka also. So, Dr. Prakash, कुछ शब्द आपकी तरफ से.
आए हुए सभी मेहमानों का और डेलीगेट्स का स्वागत. This is the second installment of the IMIDcon series, and the first installment of IMIDcon was huge success, and we look forward to this IMIDcon also to be a huge success in terms of organization and attendance. As Dr. Mukesh has already disclosed the MediFest 2021 in the first half of January. We look forward to it, and we'll certainly make it in an IMA Dwarka style. And as Dr. Yugal Mishra is also here, I'll request Dr. Yugal to take a call on that MediFest also, and keenly participate in the MediFest 2021 in a bigger way. I welcome Dr. Arun Gupta sir, Dr. Naresh Chawla, both very dear friends and very close to my heart, and I welcome them. And Dr. Deepmala, kindly take over now.
Thank you, Dr. Prakash Lal. So now is the time to welcome our guest of honor, Dr. Arun Gupta, President, Delhi Medical Council. Dr. Arun Gupta के लिए कुछ बोल नहीं सकूंगी, जितना कहें वही कम है. उनका IMA द्वारका के साथ बहुत पुराना लगाव है. Whenever we have called, he was always with us. So I hope कि इस second tenure में भी वो हमारी बात सुनेंगे और it will be a doctor friendly Delhi Medical Council. I welcome Dr. Arun Gupta, sir. Sir, please. Dr. Arun, sir.
Yes. Good evening, everyone. आवाज आ रही है?
Yes, sir.
Okay.
Yes.
So, Dr. Mukesh, the President of IMA Dwarka, Dr. Pankaj, Secretary IMA Dwarka, my very close friends Prakash and Deepmala, my very senior मेरे कॉलेज के हमारे गुरु डॉक्टर युगल मिश्रा और मेरे साथी डॉक्टर नरेश चावला और सारे मेरे दोस्त. मैंने से बोला, दीपमाला ने बोला कि द्वारका इज लाइक माय सेकंड होम. IMA DNZ के बाद मैं सबसे ज्यादा कहीं जाता हूँ तो द्वारका होता है हमेशा, एंड दैट इज प्राइमरली बिकॉज ऑफ प्रकाश एंड दीपमाला, वेरी वेरी क्लोज टू मी. और डॉक्टर सचदेवा सर, आपका भी स्वागत है. पहले में जितने भी दिल्ली में डॉक्टर्स हैं, हम सबको मैं धन्यवाद देना चाहूँगा कि उन्होंने मुझे दोबारा मौका दिया दिल्ली मेडिकल काउंसिल का प्रेसिडेंट बना करके अगले 5 सालों के लिए. 5 साल पहले जब दिल्ली मेडिकल काउंसिल को मैंने ज्वाइन किया था एज ए प्रेसिडेंट, मैं बिल्कुल ये अनभिज्ञ था कि कैसे होते हैं काम, काउंसिल कैसे काम करती हैं, लॉ क्या होता है, लॉ के बारे में बातें कैसे होती हैं. तो इन 5 सालों में सीखने को बहुत मिला. दिल्ली मेडिकल काउंसिल में वर्चुअली 25 से 30 केस हर महीने हमारे पास में आते, तो ऑलमोस्ट मैंने 1000 से 1200 केसेस इन 5 सालों में देखे हैं. तो काफ़ी हमने इसकी फंक्शनिंग को रिफॉर्म किया है. दिल्ली मेडिकल काउंसिल इज टोटली पेपरलेस नाउ. आपको रजिस्ट्रेशन कराना और री रजिस्ट्रेशन कराना इज टोटली ऑनलाइन है, आने की जरूरत नहीं पड़ती. और मैं कोशिश की कि हमारा स्टाफ भी टोटली डॉक्टर्स फ्रेंडली हो. इसके अलावा कभी किसी को भी पर्सनल कोई भी प्रॉब्लम हो तो मैं वहाँ पे हमेशा मौजूद रहता हूँ. कोई दिक्कत तो कभी हर प्रॉब्लम को सॉल्व करते हैं. पर इन 5 सालों में मैंने बहुत कुछ देखा. जो दीपमाला ने वर्ड यूज किया डॉक्टर फ्रेंडली, डॉक्टर फ्रेंडली है हमारी काउंसिल, पर मैं डॉक्टर फ्रेंडली वर्ड यूज कर सकता नहीं, क्योंकि जुडिशियल बॉडी है. जो हमारा काम डॉक्टर्स और पब्लिक दोनों के बीच में बैलेंस बनाना होता है. वी कैन नॉट बी फ्रेंडली टू आइदर ऑफ दिस, वी हैव टू फेयर विद ईच ऑल द पार्टीज. तो मैं बोलूंगा कि ये डॉक्टर्स फेयर है बिल्कुल. हम कोई भी डिसीजन डॉक्टर्स के अगेंस्ट अनफेयर जाने नहीं देते. हमारा इंटेंट हमेशा क्लियर होता है और हम पूरा डॉक्टर्स को मौका देते हैं. और मैं बड़ा गर्व से कह सकता हूँ कि दिल्ली मेडिकल काउंसिल के डिसीजंस होते हैं, जो हमारे डिसीजन बाद में हाई कोर्ट में या MCA में चैलेंज होते हैं, तो मोस्टली केसेस 99% केसेस में हमारे डिसीजन अपहेल्ड होते हैं. और बल्कि हाई कोर्ट ने कई बार हमारे फेवर में बड़े अच्छे रिमार्क्स भी दिए हैं. मैं चाहूँगा वो चीज़ें आगे अगले 5 सालों में कंटिन्यू करें. और कुछ बातें मैं अपने ओर से जो हमारे साथी लोग सुन रहे हैं उनको कहना चाहूँगा कि जो मैंने जो देखा इसमें ना, जो जितने केसेस हमारे पास में होते हैं मेडिकली, अगर हम प्रोफेशनल कॉम्पिटेंसी या नॉलेज की बात करें तो मैं देखा ज़्यादातर हम लोगों में से देर में प्रोफेशनली कॉम्पिटेंट होते हैं. मतलब आपको ट्रीटमेंट पार्ट में कोई लैकुना मिले, मेरे साथ में ऐसा कभी होता नहीं. लैकुना क्या होता है? जहाँ उसके सॉफ्ट साइंस होते हैं, जो MCA के एथिकल गाइडलाइंस है, या तो हम उसमें कहीं ना कहीं बात खा जाते हैं, या जो हमारा डॉक्यूमेंटेशन पार्ट है हम उसमें बात खा जाते हैं. अब अनफॉर्चुनेटली जब आप मेडिकल काउंसिल में आते हैं, कंज्यूमर कोर्ट में जाते हैं, किसी कोर्ट में जाते हैं, तो मेडिसिन के अलावा लॉ की बात भी होती है. इट इज नॉट अबाउट मेडिसिन ओनली. लॉ के जो स्टैट्यूटरी रिक्वायरमेंट्स है, चाहे वो कंसेंट की है या डॉक्यूमेंटेशन की है, वो आपको पूरी करनी होती है. आप मेडिकली सब कुछ सही होते हुए भी अगर आप लॉ में कहीं लैकुना है आपका, या लॉ में कहीं भी आप गलत कर जाते हैं तो आप फंस सकते हो. तो मैं बार बार ये कहता हूँ कि इन चीज़ों को जरूर पढ़ें. मेडिकल MCA कोड ऑफ एथिक्स को जरूर पढ़ लें. और जो एक दूसरा मैंने देखा, जो मेडिकल काउंसिल में केस आते हैं वो लोग लेकर के आते हैं जिनको एक्चुअल ग्रीवेंसेस होते हैं डॉक्टर्स के अगेंस्ट. क्योंकि हमारे काउंसिल में हम लोग ना फाइनेंशियल कॉम्पनसेशन नहीं देते. प्रोविजन है पर हम देते नहीं। तो जिसको एक्चुअली फाइनेंशियल होगा, जिसको लालच होगा, हमारे यहाँ नहीं जाके कंज्यूमर कोर्ट में जाता है। कंज्यूमर कोर्ट कई बार हमें रेफर कर देती है, वो बातें लगे। हमारे एक्चुअल वो केसेस होते हैं जहाँ एक्चुअली ग्रीवेंसेस बहुत ज्यादा होती है, और इन ग्रीवेंसेस में कहीं ना कहीं एक बिहेवियर बहुत मैटर करता है। मैंने देखा है लोगों को पर्सनली इतने खुंदक में होते हैं कि मैं छोड़ूंगा नहीं, मतलब वो कहीं ना कहीं मैं कहता हूँ आप ट्रीटमेंट कैसे भी करें, बहुत सी बातें होती हैं। मैं मानता हूँ कि अंडर स्ट्रेस हम लोग भी होते हैं, अंडर स्ट्रेस पेशेंट वाले भी होते हैं कई बार, पर कोशिश करें अगर अपने आप को कूल मेंटेन करेंगे, मतलब अंडर ऑल द ऑड्स, मुझे पता है कहना बहुत आसान है, करना मुश्किल होता है, अगर आप अंडर सर्कमस्टेंसेस अपना कूल मेंटेन करेंगे तो बिलीव मी जो मेडिकल काउंसिल में केस आते हैं 50% केस नहीं आएंगे। समहाउ कहीं ना कहीं उनमें फ्रस्ट्रेशंस या चीटिंग की फीलिंग आती है। जिसको जाना है भाई, जो लालची है, जो बदमाश है, जो फ्रिवलेस केस करना है, वो हमारे नहीं करेगा, वो जाएगा कंज्यूमर कोर्ट में, क्योंकि वहाँ फाइनेंशियल मिलता है, हमारे फाइनेंशियल नहीं मिलता। तो बिहेवियर में हमेशा कूल रखें। दूसरा, आपका बेस्ट डिफेंस, और ये आपको ओनली डिफेंस आपका डॉक्यूमेंटेशन होता है। कोशिश करें, क्योंकि हमारे पास जो केस आते हैं हम सिर्फ डॉक्यूमेंटेशन पे जाते हैं, क्योंकि वहां पे दोनों पार्टीज कुछ भी बोलती रहती हैं और दोनों का स्टेटमेंट कंट्राडिक्टरी होता है, आप प्रूफ कैसे करोगे? तो आप कोशिश करें आपके डॉक्यूमेंटेशन पूरे हों। तीसरा, जब आपका केस मान लो कभी भी काउंसिल वगैरह में आ जाता है, कोई घबराने की बात नहीं है, कंसल्टेंट्स आर देयर जो आपको सजेस्ट करते हैं, पर जो पहला रिप्लाई होता है, मैंने देखा जो फर्स्ट रिप्लाई आपका होता है, दैट इज कोर ऑफ योर केस। मैं हमेशा कहता हूँ जो पहला रिप्लाई आपको बहुत परफेक्ट होना चाहिए, क्योंकि वो रिप्लाई आपका, अगर उसने कल को हमारे जजमेंट के अगेंस्ट हाई कोर्ट में जाते हैं या सुप्रीम कोर्ट में जाते हैं या कंज्यूमर कोर्ट में, तो वो रिप्लाई हमसे मैटर करता है। तो उसमें कुछ बातें तो कभी, तो आज इतना लंबा टाइम नहीं है, मैं किसी दिन एक मुकेश प्रकाश उसने एक दिन ना सेशन इस पे लेते हैं कि हाउ टू डिफेंड योर केसेस, हाउ टू प्रिपेयर योर आंसर्स, दैट इज वेरी इंपॉर्टेंट। कई बार हमारे पास जब आंसर आ जाते हैं, हम ही लोगों में से किसी को होता है ना, पढ़ के कहता है यार दैट वाज नॉट द राइट वे टू प्रेजेंट योर केसेस ना। ये सारी बातें इंपॉर्टेंट है। और अब सेकंड टेन्योर में हमारा नया ऑफिस रेडी है, दिसंबर में शिफ्ट हो जाएगा, और 120 सीटर का हमने अच्छा ऑडिटोरियम बनाया है, बिल्कुल 5 स्टार बनाया है, बिल्कुल स्टेट ऑफ आर्ट, ऑडियो वीडियो सब कुछ उसके अंदर है। तो IMA द्वारका कभी भी इसको इस्तेमाल करना चाहे अपनी किसी भी एक्टिविटी के लिए, हालांकि थोड़ा दूर जरूर है, पर अपनी दिल्ली मेडिकल काउंसिल की ओर से आपको 24 घंटे अवेलेबल है, ये मैं एश्योरेंस दे सकता हूँ। और I again wish you all the success in this your CME as well as the other CMEs. Dr. Yugal यहाँ पे है, तो मुझे पता है it's going to be real feast for academicians. Thank you very much for calling me. Thank you.
थैंक यू सो मच सर। सही, आपने बहुत अच्छा बताया, क्योंकि जब भी हम DMC में आए तो वी नेवर गॉट अ सीट ऑल्सो बैठने को। तो लेट्स सी कि आप जो न्यू बिल्डिंग है उसमें how what facilities we can avail. So Dr. Prakash would like to say something.
I take this opportunity to thank Dr. Arun with his many gesture of offering the funding for IMA use. I'll further request Dr. Arun to
I think audio has gone.
Dr. Prakash,
am I audible?
अब now.
Hello.
बीच में चला गया था।
एक सेमिनार में हूँ।
Hello.
हाँ डॉक्टर प्रकाश, हाँ प्रकाश बोलो।
Dr. Arun, my personal request to you is कि kindly organize few seminars zone wise, so that we can take lectures on the soft skills, improving the soft skills of the doctors, and how to do documentation, how to do communication with the patients. All these things are very important in the clinical sector.
इसमें ना मैं प्रकाश
And this is also covered in the Indian objective.
मैं 2 घंटे का एक मॉड्यूल डिजाइन कर रहा हूँ 2 आवर्स का, तो उसको हम जोन वाइज भी कर लेंगे, सेंट्राइज भी करेंगे, जैसे आपको कन्वीनियंट होगा। तो 2 घंटे में नटशेल में एवरीथिंग विल टेल यू मेडिकल लीगल केसेस के बारे में। मैं बहुत जल्दी रेडी करके, जैसे ही हमारा नया बिल्डिंग रेडी हो जाएगा ना, देन विल स्टार्ट दैट।
Thank you, Dr. Arun, Dr. Prakash. So now we will move towards our academic field. The first topic of piece is minimally invasive and robotic cardiac surgery, and the speaker is Dr. Yugal Mishra, who is head of cardiac science and cardiovascular surgery and chief of clinical services, Manipal. The chairperson for this session are Dr. Ashish Agarwal, who is the Senior Consultant Interventional Cardiologist at Akash Healthcare, and Dr. Chaurasia. He is the Deputy Medical Superintendent at Deen Dayal Hospital, Government Hospital. He is the Senior Executive Member of IMA Dwarka, and he has recently authored the book on Corona, Which of Corona, which is the bestseller. So I welcome both the chairpersons and the speaker, Dr. Yugal Mishra, sir. Dr. Ashish, kindly introduce the speaker and Dr. Chaurasia to conclude.
Ashish, unmute, please. Ashish, unmute yourself.
Am I audible now?
Yes.
Yes, sir. Okay. Thank you, IMA Dwarka. I feel honored to be a part of this MIdcon. And thank you, Dr. Arun sir, for giving such wonderful tips. And we would certainly like to hear you more about on this topic. And I request Dr. Lalchandani to please arrange one talk from him. But now Dr. Yugal Mishra is a known figure. He needs no introduction, but I'll quickly read out an introduction for him. Dr. Yugal Mishra holds the portfolio of Head of the Cardiac Sciences and Chief Cardiovascular Surgeon at Manipal Hospital, Sector 6, Dwarka. He is armed with a rich experience of more than 29 years, having specialized in cardiac surgeries. He has to his credit more than 19,000 open heart surgeries, which include minimally invasive cardiac surgery, port access approach for valve surgery, ASD closure, carotid artery and arterectomy, aortic aneurysms, ECMO and cardiac arrhythmia surgery, total arterial revascularization, minimally invasive CABG or on beating heart, Bentals, which is supposed to be a very, very challenging surgery, aortic arch and thoracic abdominal aortic repair with excellent results. He has conducted more than 500 successful robotic cardiac surgery and 1000 redo cardiac surgeries, which also again is a very challenging surgery. He has been a leading member of core heart team for development of tower in Fortis Escort Heart Institute, and has also played an active part in heart transplantation and ventricular assist devices procedures. Dr. Mishra additionally holds a keen interest in training, education, and research work. He has to his credit more than 150 scientific papers published. His expertise in cardiac surgery is acknowledged globally, and he has regularly participated in more than 200 international and national conferences to deliver lectures. He has also played a key role in teaching and training of DNB students. His global outreach include patients who he has operated on various countries. He has exhibited his excellence in surgical procedures by performing live cases in workshop in Thailand, Bangladesh, and Nepal. Dr. Mishra has received many awards, including the prestigious Lifetime Achievement Award conferred by President Dr. APJ Abdul Kalam, and Doctor of Science conferred by Governor of Madhya Pradesh and Chancellor of Rani Durgavati Vishwavidyalaya. So over to you, sir, for a wonderful talk.
Thanks, Ashish. Let me share my slide first. Good evening, friends. At the outset, on behalf of Manipal Hospital and on my behalf as a clinical head of the hospital, along with my friend and colleague, Dr. Anurag Saxena, Dr. Randeep Badwa, thank IMA Dwarka, the President Mukesh Verma, the Senior Vice President DMA Dr. Prakash Lalchandani, Honorary Secretary IMA Dwarka Dr. Pritam Pankaj, Finance Secretary IMA Dwarka Dr. Surendra Yadav. Let me also acknowledge Honorable President DMC Dr. Arun Gupta and Vice President Dr. Chawla. There are many friends and I especially mentioned Dr. P.K. Gupta, from whom I learned a general surgery when I was working as a senior registrar in Ram Manohar Lohia Hospital. Thank you, sir, for coming to this place. Also, Arun, for your presence. Always, this gives me immense pleasure whenever I see that you are flying very high, and now you are second term of President PMC. Dr. Assis and Dr. Chaurasia, thanks for chairing this session. Now, I am going to talk about the minimally invasive cardiac surgery, what is perspective in our country, and what is specifically the role which I as a surgeon played initially when I was in a Scott Heart Institute, and now developing robotic and minimally invasive surgery in Manipal Hospital. In India, if you see the quantum of minimally invasive and robotic surgery, around 30 to 35% of the surgery is being performed in North, around 25 to 30% in South, somewhere 20 to 25% in West, and in East side is very dismal, around 10 to 15%. In India, we have around 715 cardiac setup, and out of those, the 20% of those setup, they perform some form of minimally invasive surgery. Now, if we see the quantum of volume which we in this country perform, we do around 100,000 of coronary surgery. Out of that 100,000, around 5 to 7% of minimally invasive coronary surgery. Valvular surgery we do in the range of around 60,000. Out of that, 15 to 20% we perform through minimal access approach. And the congenital we do around 35 to 40,000, after which around only 5% of those we perform through minimal access approach. Now, any evolution if comes, any innovation comes in the field of any medical sciences, including cardiac surgery, there are people who innovate that, and after that, there are people who adopt, early adopters. After that, there are some drawbacks, some problems, and there is a time gap where the people, they just wait for the results, and then early majority, the large number of people, they adopt that technology. Once it's proof is worth, eventually the late majority takes subsequently, and then there are some people who never touch that. And particularly age may be the one, second may be the financial constraint, the institutional drawbacks of not having enough infrastructures, all those things. We, as a cardiac surgeon, always were in the forefront. We adopted any surgery. I let you know, I started a robotic surgery in India, which was across the Asia in 2002, in 40s, not a 40s, but a Scott Heart Institute in 2002, which was just 3-4 years later from USA. So that's the kind of things which we are trying to adapt in this country, whether it's a minimal invasive valve, coronaries, now tower. We are trying to get those technology, and this was possible because of the corporate hospitals, which are very prompt to bring the technology, and we are utilizing those technologies. Now, why we do a minimally invasive cardiac surgery or robotic surgery? There are reasons. We all know that a patient who is a diabetic, who is a 60-65-year-old, glycosylated hemoglobin maybe 8 or 9, we very often see as a clinician that in India somehow the adherence to the proper management and in the diabetes is somewhere lagging. And we get this kind of wound, not a majority, but sometimes non-healing. And if, particularly if younger patients, we utilize 2 mammary arteries, which is necessary to have a long-term good results. We sometimes end up doing this. So to avoid that, robot is best. We will explain how. Then there is a faster, today's world, nobody wants to 3 months, which is usual after open heart surgery. to be taking a gap. Government is not giving 3 months now the leaves. So what about the other private setups? So one has to go early to adopt work. One must have a caste basis like this lady, or people must start. There are a lot of manual workers, a lot of people who do manual job. Now after sternotomy, they don't have a confidence to start this kind of work which you are seeing. So these are the advantages. Of course, another advantage is blood loss. We all know that, the HIV, HBS, AG, those are the risks in spite of so much stringent blood bank test. There are some slippage. So in my practice in Manipal Hospital today, I do 65 to 70% of the cardiac surgery without the use of blood and blood products. And that is possible because I could able to do a lot of minimal access and robotic cardiac surgery. Now, what are the minimal invasive? I'm not going to go into detail. I just want to touch superficially what are those. Now, let's talk valvular heart surgery or congenital heart surgery. What I am doing now, we started very early and I'll let you know, but Manipal, what we are doing today, we are doing mitral valves through the fourth intercostal space like this. We also do ASD closure, secondum like this, or any cardiac tumor. If there are myxomas, we can also do through this approach. For aortic valve, we use second intercostal space, thoracotomy, or upper partial sternotomy like this. What we are doing for coronary artery bypass surgery, triple vessel disease, with this fourth intercostal space on the left side. When we utilize robot, this is one robotic arm, other robotic arm, we can minimize this incision because the modern robot, which is XI system, we don't have a stabilizer, so we cannot do a total endoscopic, which earlier I was doing in a Scott Heart Institute with that, but that system is now old. So we have to make some incision, little bit incision after dissecting the mammary artery, whether a lima or bilateral mammary artery, and move on. So let's move on to see, now this is a patient who has got a mitral valve disease and need a repair. I'm going this repair through this minimal access approach. This is fourth intercostal space. We have cannulated the patient's femoral artery and vein, and through this small cut on the fourth right intercostal space, this is a P2 prolapse. P2 segment of the posterior mitral leaf is prolapsing. I am excising this. You see that P2 is I am going to excise because there is a lot of excessive tissue, and then I will stitch back, and then I will put a ring, and I will achieve one of the best results. So here I am not replacing the valve. On the contrary, I am just repairing. This is very, very tedious, even with the sternotomy, but because we have now gained expertise in minimal access, so I am repairing this valve with this approach. And this is a classic approach. Here we do a femoral artery and vein cannulation. Here we make a fourth intercostal space like this. Sometimes we use endoscope, and with this small incision we could able to repair. You see this we have repaired. There is no leak, and then we will put a ring. This work I started, you see, in 2002. I published this paper, minimal invasive mitral valve surgery, and I have done more than 1,000 such cases. And we started already. I have crossed somewhere around 100 cases in Manipal Hospital. And then this is a ring which we have to fix to get a long-term results. Now, then let's move on to how we do ASD closure. So this is again fourth intercostal space, ASD secondum. For ASD, the sinus venosus I do into second, right? This is a ASD secondum, which I am putting a patch. This is a synthetic patch which I am putting into the defect in the atrial septum here with this small incision and repairing. This work also I started way back in 1999, and this is a paper which I published in Indian Journal of Indian Heart Journal way back in 1999. This surgery now I started doing with the robot. I will let you know how that. So let's move on and see the next one. So I can also started doing a reduced valve surgery. Patient who had a primary surgery, now they have a complication of paravalvular leak or stuck valve, which can be done through the minimal access approach. This is very important because then they need not to go to the resternotomy and there are a lot of regions, we can utilize a mini approach and do. This is another paper which I published in 2002 in Asian Cardiovascular Journal, our experience of redo surgeries, and that has now moved on, and I have accumulated a lot of experience in this area. Now, aortic valve. Aortic valve one can do in a two way. This is a femoral artery and vein exposure for going onto the heart-lung machine, putting the both cannulas. And after doing that, one can go into the thoracotomy, second space, right side, or upper partial sternotomy, and this, and replace. Now, upper partial sternotomy is required, particularly the female who I got a big breast. So, not to deform the breast, I usually take upper partial sternotomy so that this area is not being. But in a male case, I use this. You see, this is incision in the second intercostal space on the right side, and through this small 2 inches incision, I am now incapable of replacing the aortic valve. Even with upper partial sternotomy, you can see like here, this is upper partial sternotomy where I can even do the proximal arch replacement, Bental procedures with this approach, upper partial. Rest of the sternum is intact. Here you can see this is a classic, the exposure of aorta, because when you are replacing the aortic valve, why to expose whole of the heart? You don't require to expose the heart, because you only require aorta to replace and do the workout in the aorta, take out that degenerated valve, calcified valve, and then replace with synthetic or with a mechanical valve, whatever you can. And in this particular case, you can see that I'm utilizing a mechanical valve here. And this is a mechanical valve which is being used. And here in this particular case, I'm going to use a tissue valve. Reason is that this is a patient who is more than 60 years of age. Hence, he needed a tissue valve like this. So this is a tissue valve in this case, and thoracotomy patient, young patient, where I utilize a mechanical valve. Move on to some other procedures. Now, coronary artery bypass surgery. Now, Assis and all, they do a lot of, the angioplasties. Now, in a situation where there is osteal LAD, or there is a restenosis of the stent which they have put into the proximal LAD. Now, this is the best procedure where we can utilize mid-caps, make a small thoracotomy, take down the lemur, and put into the LAD. This is the best graft, has got a 98% 5 years patency. So this is particularly indicated when either there is a osteal LAD lesion or there is a restenosis of the stent which is put into the proximal LAD. We also use this for triple vessel disease, and I'm going to take those things, how we do that. Now let's move on. How we can take down the memory. This is a thoracotomy memory. Now, and here I am using the robot to take down the memory. You can see here, these are the robotic arms, and I'm trying to take down the memory. Lima, like here, this is a lima which I'm going to take down with the help of a robot, and here I'm utilizing direct vision. This is, we call it MICAS, where the robot is not being used. This is memory. You can see very nicely skeletonized memory is being dissected, and then if it is only single vessel, then we call it a lima or lima and diagonal sequential. We can utilize this. Or we can take down another rima, and then with the help of only rima and lima, either we make the ipsilateral or crossover, or we can make a lima rima Y and do all the 3 vessel bypasses. With the robot, we can utilize, you see that here. Now the advantage of robot is we don't retract too much of the ribs, hence the pain is very less. The patient is very comfortable, and we just put in a tissue retractor and carry out this, the procedures. So just I want to give these glimpses and move on to just show you one triple vessel bypass, and this is here. You can do a single vessel, which I just mentioned. If there is osteal LAD or stenosis, we have started this long time back in 1997, where mini thoracotomy, and you then done around 1,000 cases, 500 thoracotomy, 500 lower partial stenotomy, and this is one of the paper which we published in Asian Annals in 1997. We also published subsequently our papers in multi-vessel targeted approach. Now the patient who has like triple vessel bypass. Now if the lima is working well and the saphenous vein graft to the circumflex and PDA block. Then we use another, this is, the procedure where we utilize triple vessel bypass. Here I am putting a proximal anastomosis through the fourth left intercostal space opening. This is just 3 inches incision, and with these long shafted instrument, we utilizing different kind of technology. Our hand cannot reach to tie the knot. Hence, I am using these knot tires because the incision is such a small and the aorta is far away. So I am utilizing these things and putting these 2 veins and mammary artery, which is already being dissected with the help of robot. With these 3 vessels, to bypass can be easily done, Lima to LED and 2 vein graft to the rest of. I'm just going to just show you just glimpses how we do the distal anastomosis. Now this is a stabilizer which we put from a different route. Make a small step, we push this long shaft, and then we stabilize this area. Heart is beating and I'm doing the bypass. You see, this is a Lima which can be grafted to the LED. This is LED target which I am exposing. Heart is beating, only localized area where I'm going to do a bypass is being stabilized with the system. This is a different kind of octopus, not a usual octopus. You can't see the octopus here, which is being pushed through other separate wound, and so the Lima to LED is going to be grafted. This is a Lima which is been dissected, and I'm going to put this graft to the LED on beating heart. Not only this one, this is a Lima which can be grafted. We are going to put the venous graft. You see that this is another target. This is a lateral wall where I'm putting the saphenous vein, which is already been the graft grafted into the aorta here. And now with the same, I'm going to put this venous graft to the lateral wall of the patient through that small targeted incisions, which is here, and the sternum is not being touched. Heart is beating, and we are doing triple bypass with the 3 inches thoracotomy incision. So just move on. I'm not going to take much of time to this one. Not going to just give you glimpses of what we are doing at this stage in Manipal. Now, robotic system. We started robotic, I already mentioned 2002. We published this ever paper in the robotic 2006, where we utilized robotic assisted coronary artery bypass surgery. Now, I mentioned that this robot, which is a first generation robot, we had a stabilizing system. This is a Lima to LED is being harvested. Then we go and stabilize. This is a LED, this area was stabilized with the endo stabilizer, and we completed Lima to LED anastomosis. And you see, there is no incision. These are small port. This is for endoscope. This is for right arm. This is for left arm, and this is for stabilizer to stabilize the area. And with this, we could able to do double or triple bypasses on beating heart with the help of robot. This paper we have published in Journal of Robotic Surgery in 2007. Now, mitral valve. So what is the robotic perspective? This is a coronary artery bypass surgery. I dissected the 2 mammary arteries, Lima and Rima, and did 2 bypasses. Then you can see the robotic mitral valve repair. Here you can see that the P2 is prolapsing, and there is a bulky. This is a myxomatous degeneration. I'm going to utilize a robot to resect the P2 segment and do the sliding plasty and do a perfect repair. Now, the beauty of a robot to use for this repair is you can have a 3-dimensional vision. You have depth perception, and you can zoom to the robot up to 10 times magnification. The only problem is that we don't have tactile feedback. We can't, when we sit in the robot, we can't feel the tactiles. We don't have that one. That's the only thing. Hence, stitching with a small thread is a problem. So now here you see that I'm reducing the height of P3 and P1 segment, and I have excised the P2 segment and going to restitch that with the help of robot, and then deploy a ring like I'm just going to show here. Now this is restitching that excised segment, and after doing that, one can deploy. This is a band, like we utilize band because ring introduction is a little difficult, and use this trigone to trigone and make a valve very competent. And this I am going to show you. This is a ASD closure with the help of robot. This is a ASD which I'm going to utilize direct closure here, and close this congenital defect utilizing robotic system. And you see that this is a small defect, but the inferior margin was deficient. Saying the Assis and all, they cannot able to close that because the one margin is deficit and required a surgical closure. And this is the best option, particularly female patients, very scarred. I have done, by the way, the ASD closure with just periareolar incision, just making an incision around the areola and not cutting any skin, and which is virtually like a scarless incision and closing the now these are robotic system which we have, which we, this is a surgeon's console. This is a robotic arms which go to the patient, and these are the vision system. The very advanced vision system, and this has got 3-dimensional, very high definition camera. So we get a picture from here to here, and I operate. The surgeon sits here and have intuitive pictures, and he can see, assistant can see there. With this, now these are the various procedures which can be done. Now cost is an issue. Now there are only 4 hospitals in this country. One is the Manipal Dwarka, one is in Bangalore, Apollo Chennai, and Apollo Hyderabad. These are 4 centers in whole country who are doing robotic cardiac surgery. These are the only in North. So Manipal Hospital is the only center now who is doing robotic cardiac. There is no other hospital, neither Medanta, neither the Escort. No one is doing, because I don't know what is the reason, but this is the only center, Manipal Hospital Dwarka in the North, which is doing robotic cardiac surgery. So this is our team. We have got this display, and this is already I mentioned about the advantages of this thing. Precision is there, and this is our the Manipal when we joined in 2018, and this is our surge of all the minimally invasive procedures here, and this shows the regular surgery, and the which is green, and the pink is the minimal access surgery volume, and this is a whole the picture height is, this is a conventional heart surgery. This is a mitral valve replacement, this small cut. And when we utilize a robot, the incision becomes much smaller. This is a coronary bypass surgery, regular. When you utilize, the lower partial stenotomy to use 2 mammary arteries. When you use a robot, we can dissect the robot and do the triple vessel. And this is totally endoscopic coronary artery bypass surgery. For this, we need training. I have gone a couple of times to various centers, must have visited 20 centers all over the world, North America, Europe, and recently Korea is very active. I have recently, 8 months back, I have gone to Korea to refresh this new system. We are also collaborating with other centers in the world. And my own, the effort is to train. We have conducted 14 cadaveric session in Ramaiah Advanced University in Bangalore and trained many people. I could able to treat 144 cardiac surgeons with my friend Dr. Satki Nambala from Bangalore. 2 of us could able to train 140 senior surgeon in this country to start a robotic cardiac surgery. I started a minimal invasive association, which is known as Indian Association of Minimal Invasive Cardiac Surgeon, and this is our one of the meeting in Mumbai, and these are our members of the associations. Now, this kind of surgery, we need a perfusionist to be trained, anesthetist, of course, should be experienced, and what have we learned over the last 30 years has to be utilized. And the most important thing which we learned is to work as a team for patients' benefit. Cardiac surgeon, radiologist, interventionist, vascular surgeon, and everyone has to come together. There is nothing like me or we. This is we, and I'm lucky that I am heading the cardiology and cardiac surgery department both here in Manipal. So I could able to have a very good collaboration between the cardiologists and cardiac surgeons, and of course with other the stakeholders of the hospitals. With that, I should say for this kind of surgery, we need commitment, practice, patience, and of course, persistence. So success is moving from failure to failure without loss of enthusiasm, as Winston Churchill said. Thank you. Thank you, friends, for your patience hearing. Thank you. Thanks a lot.
Thank you, sir, for enlightening us with your rich experience and beautiful cases done. I want to ask one question to you, sir. what in your opinion is the reason for such less number of minimally invasive surgery? It is lack of infrastructure, lack of equipment, or the financial constraint?
All the three things. All the three things. So now I let you know that minimally, I'm not talking of robotic. Robotic is altogether different perspective. Now the robotic is much more used by our colleague, Dr. Randeep Badhavan is going to talk to you, our urologist. Now there are, when the robot started, this was started particularly for a heart surgery. Eventually, because of the fact that you know very well that patient who has got low EF, if we inflate with CO2, his blood pressure drops. So we don't have much space. When we do the robotic surgery, we put off left lung, and particularly the heart is sick. Now when our friend Randeep does abdominal surgery, he can bloat the abdomen with CO2. There is no issue. But when we bloat the the thoracic cavity with CO2 to create a working space, now there is a compromised hemodynamics. So that was the issue. And then the robotic, when they came, the robotic arms were not very surgeon friendly. They were crude. Now things have started moving. But other issue is finances. Now the robot costs 16 crore rupees, which is very expensive. And each instrument costs $1,000, which can be used only 5 times. Now there is other company, Medtronic, has come out with a robot. Now in future, we are going to have a cheaper robot. Now minimally invasive surgery, I mentioned there are 22% of the centers. In Delhi also, there are so many centers who are doing now minimally invasive. Not a coronary, which is most difficult, triple vessel, but they do mitral, they do ASDs, they can take down the atrial myxomas. So now there is a lot of enthusiasm, and I tell you that I am the president of Indian Society of Minimal Invasive Heart Surgeons since last 5 years, and we could able to contribute, and we see we have done this is started 6 years back. Now we have done already 5 meetings, one in Delhi, one in Jaipur, one in Bangalore, one in Mumbai, and this year, the virtual meeting from Delhi, and we see a lot of enthusiasm in our. So now this is basically is now the hospitals are ready to invest, corporates are ready to invest, and even government hospitals. All India Institute, after SCOT, All India Institute was the second center who got a robot. This was, I'm talking 2002, 2003. Now All India Institute has 2 robots. The Safdarjung Hospital has 1 robot. And the Rajiv Gandhi Cancer Institute has 1 robot. So now there are a lot of initiative. Cardiac surgery, robotic is very difficult, and of course, doing a minimal access triple vessel bypass is not it's not a joke. This is a really need intense training, and of course, a very experienced surgeon and a very good team. One has to have a very good team. I could able to move with 40 people from Escort to Manipal Hospital. All my technician, anesthetist, assistant, they all come with me. And I joined the Manipal on 15th of October, and 16th October I started operating. So one need to have infrastructure and vision, which gives you opportunity to operate upon. Thank you.
Yes, definitely. I think one thing we should say thanks to the corporate hospitals for providing us enough infrastructure. So thank you very much, sir. Audience, any questions?
I'll ask Dr. Chaurasia to conclude. Dr. Chaurasia? Okay. Then Dr. Ashish, kindly conclude it. We'll move to another session then.
Right. So thank you very much, sir, for your wonderful interact session on the minimally invasive and robotic surgery. Once again, congratulations to you for being only person in the entire North India for doing robotic surgeries. But would urge that you should spread this awareness. You should spread your knowledge and expertise to other people also. Thank you very much, sir. I think we should move on to the next session.
Thank you, Dr. Yugal Mishra, Dr. Ashish Agarwal, and Dr. Chaurasia. Now we'll move to the second topic, is comprehensive care for neurosurgery. And the speaker is Dr. Anurag Saxena, who is the head of the department and consultant department neurosurgery. And the chairpersons for the sessions are Dr. P.K. Sachdeva. He is the head of the department neurosurgery at Venkateshwar Hospital. Very eminent neurosurgeon. He has kindly consented to be our chairperson today. Thank you, Dr. Sachdeva. The another chairperson is Dr. Bhatnagar, sir. Dr. Bhatnagar is a senior family physician Dwarka and past president of IMA Dwarka. Smiling face देख के सबको I think अच्छा लगता है. So I welcome Dr. Sachdeva and Dr. Bhatnagar to introduce the speaker and conclude the session.
Hi, good evening, everyone. I am Dr. Sachdeva this side. Thank you very much, IMA Dwarka, for giving me this opportunity to chair the session, which will be presented by Anurag Saxena. Before starting his introduction, I will congratulate Dr. Arun Gupta and Dr. Naresh Chawla for joining as a president and the vice president of Delhi Medical Council. Anurag has recently joined Manipal Hospital as a head of the department of neurosurgery. Probably, I think this is my second interaction with Anurag. Before it was in one of the meeting on neuro-oncology. He has passed his MBBS and MS from MGM Medical College Indore, and after that he did his MCH from my alma mater from GV Pant Hospital, and then he moved on to have higher education abroad in England. He did his FRCS from Edinburgh, and then he did his fellowship in pediatric neurosurgery and spine surgery from UK. So before joining this Manipal Hospital, he was working with Narayan Hidyalaya. And I welcome Anurag Saxena to Dwarka community, and I wish you a grand success in future. I hand it over to Anurag. Anurag will tell us something about the neurosurgery status in Manipal Hospital.
Thank you.
Welcome, Anurag.
Thank you, Sachdeva sir. Thank you for the kind introduction. I'll just quickly share my screen. So is my screen here? So yes, my screen is visible to all. So hello, am I audible?
Yeah.
Okay. So just before starting, namaskar, and thank you for having me here on this forum. This is my first meeting with you all, respected chairpersons, seniors, and dear colleagues. So when we say about comprehensive neurosurgical care can be explained in different contexts. But right now with this topic, what we'd like to share with you is the scope of services at Manipal Hospitals, Dwarka, and neurosurgical patients. What can we offer and what is the scope of services for both brain and spine, be it adult or a pediatric patient. Dr. Sachdeva has kindly introduced me, so I'll quickly rush through the slides. So my journey started from GB Pant Hospital. Now, because I'm new to this forum, so I'll just take few slides to introduce myself. After my MCS training, I moved to UK for further training abroad, and most of my training in neurosurgery has been from United Kingdoms. I've done my fellowship in pediatric neurosurgery from Alderhay Hospitals, Liverpool, which is one of the biggest centers for pediatric neurosciences in the country and in Europe. Then I did my neuro-oncology training from University Hospital of North Staffordshire, where I was senior clinical fellow. I've been to University Hospital of Wales as a senior registrar, a chief registrar, and I did my spinal fellowship from Royal Preston Hospital, from where I did my FRCS in neurosurgery. And then the journey brought me to India. So I have been head of department at Apollo Hospitals Indore, which is one of the biggest corporate tertiary centers in central India. Then I was with Narayana Health and Narayana Super Specialty Hospital, Gurgaon, as senior consultant and clinical lead. And currently I'm heading the Department of Neurosurgery at Manipal Hospitals, Dwarka. Now, the expertise of our department lies in neuro-oncology, minimally invasive surgeries for both brain and spine for both adult and pediatric patients, complex spinal surgeries, functional surgeries for brain and spinal cords. Pediatric neurosurgery is one of our very strong fortes, and vascular neurosurgery, skull-based surgeries, hysterectomic brain surgeries, and peripheral nerve surgeries. So coming back to the topic, evolution, as we all know, is a fact of life, law of nature, and we all know as doctors, the guidelines and the techniques which are gold standard today or are the standard of care today will become obsolete tomorrow. And we all know sometimes they become contraindicated the day after. It's all because of the evolution going on, and nothing explains it better Then this picture of pituitary surgery, the evolution of transfemoral surgery, which has gone. So my training started here when we used to use a C-arm to do and microscope to do a pituitary tumor surgery. Eventually, it evolved to endoscopy, and now we are doing this surgery via an endoscope. Now, further evolution has given us very good navigation systems. So now we are able to navigate our endoscope into the brain, and we know where exactly the tip of our endoscope is, where exactly the blind areas are, where the endoscope cannot see, but the navigation will tell us exactly where we are. That increases the resectability of the tumor and decreases the complications and risks. Evolution in spine surgery can be explained by this slide. So prehistoric eras, Hippocrates, this is a diagram depicting how he used to treat spinal patients. He used to sit on their back and used to give traction very much similar to the physiotherapy traction machine nowadays. This is Sushruta from a museum operating on the spine of the patients with instruments which currently looks like modern day nibblers. Now, majority of the part of India currently is at this stage. We are doing spinal surgeries, be it tumor surgeries or fixations or complex deformity corrections via giving a big cut in the back, causing muscle dissections, denuding the muscle, the bones, and putting screws and implants through it. Evolution has brought us to percutaneous techniques. So we are now putting screws through percutaneous techniques without causing blood loss, muscle dissection, minimal complications. We are putting tubes in to take out tumors. We are putting tubes in to take the disc out, putting implants in. And nowadays, the next evolution step is the robot. So crossroad in neurosurgery, in fact, in any surgery, as Mishra sir has already told, is whenever a patient comes to us, there are 4 important questions in the mind of a surgeon, especially cost control in our part of the world, whether the treatment I'm giving to the patient is cost effective, whether the budget the patient has given me, especially in the private sector, whether I can perform to best of my ability in that budget, and how can I do it? What surgery I'm providing to the patient or I'm offering to the patient, whether it will give me the patient the desired results. How can I minimize my signature or my footprint on the patient, which means how can I minimize the complication and how can I minimize the scar, which leads to the 4th point, which is cosmesis, which is becoming more and more relevant nowadays in our society. Most of the time, the most common questions asked to surgeons are, sir, टाँके कितने आएंगे? The most of the time, the neurosurgeon is asked, sir, पे बड़ा scar तो नहीं आएगा? The younger girls are very, very apprehensive of having a scar in their back. They cannot wear saris for the rest of their life if they get a big scar on their back. Sometimes an ugly scar on the neck can cause a lot of psychological stress. An answer lies in similar recent advances and minimally invasive neurosurgery. And this all 4 questions are answered by this simple answer. So I'll quickly brush through the spinal part and then I'll go to the neurosurgical part, but both the brain part, both for adults and pediatrics. So minimally invasive spine surgery, as we all know, keyhole surgery. We do it with small, simple cuts. We make simple corridors, very tiny corridors to reach the desired part of the brain or spine. We cause less pain. We do minimal complications. Patient recovery is faster. Early ambulation and cosmetically much better. Beautifully portrayed by Dr. Yugal Kishore Mishra before, what are the implications of minimally invasive surgery. And this picture depicts it very beautifully. So it's a big cut in the back, lot of muscle dissection, lot of denuding of the normal structures from the bone to put an implant or to take the tumor out, to take part of the bone out. If this is an open surgery, vis-a-vis compared to a minimally invasive spine surgery, you do a small cut in the back, you do not dissect muscle. You do not coagulate muscle. You do not cause necrosis. You just put a simple endoport in. Through this port, you can either put implant, you can take the tumor out, you can take the disc out, and the end result is a very tiny scar in the back. You have respected the anatomy and the patient is very happy. He will be discharged early. There will be no post-operative pain. There will be no muscle necrosis. Now coming to bread and butter of all of a spine surgeon. So this looks a very innocent MRI. You see the nerves, the spinal cord lying there, the nerves cauda equina lying here, the disc and the bones are lying in their place. But if I tell you that this is a post-op scan, this is not just a normal MRI scan. This is a post-op scan of this patient. This patient has this herniated disc, big disc herniated inside the canal, has been operated. and the surgeon has left no footprint whatsoever, very minimal footprint on the scan, obviously done by an endoscopic technique, which is this. So normally we are doing this kind of techniques by putting small tubes. It has been very common in our part of the world now. And fortunately, most of the centers now have this kind of technique. But again, what has evolved is the expertise, the learning curve has shortened, and at the same time, the quality of equipments what we are getting, the systems have evolved massively. So what we do is normally we just put a small cut in the spine, in the back. We just put serial dilators to dissect the muscle apart, and we put the tube in. Now this tube can work as a port to take your disc out, to your tumors. You can put an implant, and you can put your screws in it. We also do disc replacement surgeries, which means in certain selected cases, we can remove the entire disc, and rather than fusing the patient's spine, we put artificial disc, which will give you the same degree of motion in forward bending, lateral back bending, lateral bendings, and rotation as a normal disc will do. It is especially good for younger people with the less of degenerative changes and cervical spine people. We used to do it very frequently for athletes in UK. Vertebroplasty, kyphoplasty is not new. It has been old, but what has evolved is the technique. We are doing it as a day case procedure nowadays. The cements have evolved and the technical know-how is involved. So I'll give you a very typical scenario: 70, 75-year-old female with an osteoporotic fracture, has a fall in bathroom, is a stable fracture. The normal guidelines is 6 to 8 weeks of bed rest, strict bed rest, so that the fracture will heal, and just pray to God with give some calcium, vitamin D, or maybe terapetite injection. But they do not heal. They normally do not heal because of the poor bone quality. And this patient lies in severe pain for, they will develop a UTI, will develop a bed sore, and the life becomes a misery for a 75, 80-year-old patient. Imagine if you can put a cement into this patient, that exothermic reaction kills the nerves, relieves the pain immediately, gives the bone strength, and we are able to make this patient walk within 4 or 5 days. So we can make a huge impact in the quality of life in this kind of patients. Other indications of putting cement into vertebral prostheses are screw augmentation for osteoporotic fixations, tumors where we can put cement in and embolize, especially vascular malformations. The example here is this simple, a 74-year-old lady who came to us with a very similar problem, fall in bathroom, was in bed for 4 weeks, came from Hyderabad to visit his son, had a fall, and then she was stuck with bed for 4 weeks. X-ray looked very similar. X-ray, the referring X-ray also looked similar, so there was no fracture, but CT scan showed a burst fracture, and cement was put in. Another patient with a similar picture, and with a few words of encouragement and other things, patient started gradual mobility, and this 4 weeks bed-ridden patient started to walk within a week of rehabilitation and physiotherapy. Traditional spine approaches, as we have already talked, includes a lot of muscle dissection, a lot of pain, muscle necrosis. Once you have put an implant in, the muscles cannot retouch to their normal bony structures, and that causes necrosis. And what the patient is left with a pain which you give as a surgeon, so which is not desirable. So that's why the technique has evolved to percutaneous technique. So what simple cut in the back, you just separate that particular part of the muscle which from where the screw will go in. Rest of the muscle remains attached to the spinal part, and you maintain the anatomy, you respect the anatomy, you maintain the midline structures, and the patients go home very, very early. So this is the normal setup. This is what our systems, normally a minimally invasive system should look like. The OT setup should look like as OAM. We're going to have it soon. A neuro navigation system with the reference points. The screws goes on the guide wires through the MCD needles. Now this is the system which I was trained on in UK. It's a Sextant system from Medtronic, and this has been taken off shelf now. So the evolution is so rapid and so fast that the systems which are gold standard today will be off shelf very soon, maybe in coming 1 or 2 years, and newer systems are coming up which are very, very less traumatic and are giving excellent results. So imagine a big cut in the back, a big sore muscle in the back, and this tiny screws, tiny cuts in the back. So obviously this patient will have an early recovery. Just to reiterate my point, a 55-year-old police constable with a severe leg pain and urinary retention following a road traffic accident came to us in severe pain with a burst fracture. We gave him both options. He went for minimally invasive technique. This is the surgical planning, how it has been done. The screws are, everything is planned. This is the intraoperative picture. The screws are placed through the skin. We do not give any cut in the midline. We do not dissect muscles. This is how it looks like during the surgery. And with tiny cuts in the back, we were able to do that. This is 6 weeks after follow-up. You cannot make out that the patient has undergone a spinal fixation surgery. and he is happily walking after a few weeks after surgery without any pain whatsoever. Another case, very similar case, fixation. So this is the summary of how things are done. Everything is done through the skin. You do not dissect or you do not cut the normal anatomical structures. Your hand-eye coordination is very paramount, important. Learning curve is slightly longer, but again, with time, you see you have to do certain complications to learn it hard way also. It is bloodless. It is virtually bloodless. There is no blood loss whatsoever. There is no muscle necrosis whatsoever, and you are able to achieve fixations with tiny incisions. There's a tip of my finger. You can see there. So this patient is again walking. So now we have evolved further. We are using 3D C-arms and spinal neuro navigation. So what we do is we make a CD and we feed it into the navigation system. We take a C-arm shot and we feed it into the navigation system. And we do not do any X-rays during the surgery. So no radiation exposure to the patient, minimal radiation exposure to the surgeon and to the rest of the team. And this is how we do it. We do it and exactly tells us where exactly our screw is going to be, where the implant will be, and results are excellent. Minimally invasive retractor surgeries for like an 18-year-old female, known case of pulmonary tuberculosis, weakness in lower limbs, bedridden for 1 month. She had a paraparesis between 3 and 4, and planters were upgoing. Hemoglobin was 6.5. Cherry on the cake was she was engaged and was about to be married. So when she came to me, she was in a pretty bad shape. She didn't want hemoglobin was I couldn't afford a blood loss. Patient couldn't afford a scar. So we use MIS retractors, special retractors, makeshift retractors, and then take the tumor. And they decompress the spine, and she started walking few days after surgery with a very tiny incision at the back. Now, spinal dysraphism, a fair share of my surgical procedure. Scissoring of gait as she was growing through a growth spurt. So because there was a spinal lipoma here, sitting here, which was tethering the cord down, the skeletal growth, the cord was not able to move up with the skeletal growth, and she started having an elastic effect, which is called as a tethered cord syndrome. And it was imperative that this lipoma has to be removed and the cord has to be detethered, otherwise she will develop permanent symptoms. The red arrow shows the spinal cord and the nerves. Now, some of these nerves are functioning, some of them are non-functioning. Previously, we used to leave this kind of nerves not knowing what are not a non-functioning nerves, and cutting those nerves seriously helps in detethering. But previously, we didn't have any idea how to identify this kind of nerves. Now, with very sophisticated neurophysiological monitoring systems and good neurophysiologists, now this is yellow arrow shows the nerve stimulator. We stimulate these nerves, we see a response, we stop there, we do not cut it. The moment we don't see a response, we cut it. So it helps to make the neural placard loose. So the detethering effect and the elastic band effect can be achieved. So you see this lipoma has been completely excised, and this is the reconstruction of the neural placard, which means construction of the spinal cord. Again, was nature left it open, we just repair it and then do a generous duroplasty, and patient did very well. Navigation guided brain surgery is not new. We have been doing it for quite some time, but the systems have improved a lot. The registration is much faster. They are very precise and very accurate. Nowadays, we do not use frame stereotaxic surgeries except for only few cases. Most of the time navigation is helping us a lot. So this again, a tumor sitting on an eloquent area in the motor cortex, 1 millimeter here and there will cause devastating hemiplegia, but we were able to remove this tumor in toto with help of neuronavigation system. Now this is an old system, but the newer systems are pretty accurate. Again, another example, before surgery, there is a big meningioma sitting on the left side. Patient presented with a stroke, finally an MRI found to have a big meningioma, was taken out from the eloquent cortex without any damage to the surrounding brain structure and did very well. Pediatric patient, 12-year-old boy, topper of his class, had started having double vision. Then school performance declined, cognitive behavioral changes. MRI showed this tumor sitting right at the cellular supracellular region with a cystic component, was excised with help of microscopic and neuronavigation technique, and he is back. He's back to his normal lifestyle, and he's doing his online classes, and his performance is picked up now. we were able to remove complete tumor because of help of modern equipments which we had. Now, this is fluorescein guided tumor removal is something which has helped us a lot in removing tumors from areas of where the tumors are there, of the eloquent cortex areas like motor cortex. For example, this tumor here just lies near the motor cortex, and again, few millimeters and here and there, we would cause a devastating deficit to the patient. So fluorescein has an advantage when you give it to the patient intravenously just before surgery or at the time of induction. There is a selective uptake in the tumor area and the tumor glows, but the normal brain parenchyma doesn't glow. We need special filters for our microscopes. They are called as yellow filters, 560 filters, and this filters helps us to see the tumor which is glowing in the star, and the normal cortex is spared, and we are able to remove the tumor out in toto without causing any damage to the brain. So again, a fantastic result without any damage to the surrounding brain structures. 60-year-old female, another case, came to us with severe headaches, bitemporal visual cuts, bitemporal visual field deficits. There was a big pituitary tumor, stellar suprasellar tumor sitting there, causing pressure on the optic nerves and a lot of other problems to this lady. She underwent endoscopic surgery. Now, we all do endoscopic pituitary surgeries, but what we have used now in this kind of systems is we actually navigate our endoscope with neuro navigation system. So just like the GPS, it will navigate the tip of my endoscope inside the brain, exactly where I am lying, what structures lie ahead of me, because I'm completely blind. I have a bird's eye view only. And on the sides, we have carotids. Upside, you have optic chiasma. You have hypothalamus, third ventricle, a lot of important structures, and simple few millimeters here and there will cause devastating complications. So we did an endoscopic transsphenoidal surgery for this patient. This last picture shows the endoscopic view as well as the navigation view exactly where we are. So it makes us doubly sure, and the complication rates are reduced and the resection rates are improved. Complete removal of the tumor was achieved, and patient was discharged 3 days after the surgery. No CSF leak whatsoever. So the technology is helping us in providing good results, reducing hospital stay, reducing complication rates, and obviously cosmesis. Skull-based surgery is another surgical part which we do, like a planar bisphenoidal meningioma sitting just below the anterior cerebral artery, which was removed by a basifrontal approach. Now, before the navigation event, when the navigation got so sophisticated that we were able to hit accurate targets, tumors like this in an 11-year-old thalamic glioma were left on the mercy of nature and got to, radiotherapy was given, palliative radiotherapy was given, and we didn't used to know what is the nature of the tumor. Now, with precise localization, we can put biopsy needle inside the brain very safely, and we can take the part of the tissue out and send it for histopathological examination. This is called as neuronavigation guided biopsies of the tumor. This is especially useful in deep-seated lesions where surgery will cause devastating complications. Now, it helps us in prognostication, it helps us in planning surgery if at all required, and palliative treatment like radiotherapy. So again, things have evolved and make the treatment much better in this kind of cases. Complex hydrocephalus, putting a shunt is easy, but in cases like this, like 27-year-old patient with a post-traumatic decompressive craniectomy, when he was referred to us with this size of head. Post-ventriculitis, hydrocephalus, multiple loculi inside the brain. So if you put a shunt into a simple loculi, it will just drain one loculi and rest of the brain will remain under pressure from the hydrocephalus. So the challenges here are, how can I convert the whole brain into a single cavity? And how can I gradually decompress the brain? So if I put a fixed pressure shunt, there will be a sudden decompression. I do not want that because that can have complications, because he has been like this for at least more than 6-7 months. So we did a navigation guided endoscopic septostomy and a shunt placement, which means that the endoscope went in, we break all the loculi inside the brain, knowing where our endoscope is in the navigation system and seeing inside the brain, we put a shunt in. So this is an endoscopic picture of the shunt going inside. And this was a programmable shunt. So programmable shunt gives me an advantage of increasing or decreasing the CSF flow. So we can gradually increase the CSF flow rather than a sudden gush of fluid. And we were able to achieve this within 2 months time, roughly around 1.5 months. And now this patient will undergo a cranioplasty. Last few slides, moya disease stroke. This is a disease which is unique, that the blood supply to the brain starts to decrease. It is a bimodal presentation. For those who are not aware, it is a Japanese word moya moya, which means a puff of smoke. What actually happens is the internal carotid arteries and the arteries supplying to the brain actually starts to shrink for reasons largely not known. So the blood supply to the brain starts to shrink. The major arteries, internal carotid, middle cerebral and anterior cerebral arteries start shrinking and the blood supply reduces. In an effort to increase the blood supply, the brain starts to get an abnormal collateral circulation from branches of external carotid artery at the base of the skull. And it gives a picture of puff of smoke when you do an angiography. These abnormal collaterals, they are not able to supply blood properly to the brain. They are fragile, so they break, they can cause hemorrhages. And this is what these patients present with, repeated hemorrhages and infarcts. And eventually, in due course of time, the disease is progressive and is fatal. So 34-year-old gentleman who presented to us with seizures, repeated attacks of hemiparesis, gas palsies, came to us in GCS of 8, gradually improved to 14. Imaging showed hemorrhages, old infarcts, newer infarcts. Pictures were not adding up, so we went for a DSA. DSA showed moya moya disease. So you can see the internal carotid artery is thinned out and there are hardly other arteries visible. Now, this is a bimodal peak. So most of the pediatric patients also present with this kind of picture, and then a bimodal peak, then certain adults also present with moya moya disease. Now with surgery, we can increase the blood supply to the brain. There are two ways of doing it. We do a bypass surgery, which means we do a superficial temporal artery, which is a branch of external carotid artery, which supplies the scalp. We take this artery and we anastomose to the middle cerebral artery of the brain, which directly increases the blood supply. Majority of the time, it is not possible because the disease presents to us very late in our country, and the MCAs shrink so much that we cannot anastomose, or the anastomose will stenose. So most of the time, we are left with an option of indirect vascularization, which is what we did in this patient. So superficial temporal artery was dissected out and it was put on the brain surface. This is called as encephaloduroarteriosyngiosis in neurosurgical terms, which means indirect way of increasing blood supply to the brain. So we dissected out the superficial temporal artery. We did a craniotomy. We exposed the brain surface. The artery is put on the brain surface, and with time, there is this artery in continuation going. It has not been, the upper end has not been sacrificed. This is in continuation, just going inside the brain and coming out of the brain. That part of the artery is still pulsating inside the brain. The brain starts to parasitize the blood supply, and eventually the patient starts to improve with due course of time. Now, this is the post-operative picture of this patient. He is a shopkeeper. His calculations went down. There was a big cognitive decline. His business got completely devastated. Now, with his help of his wife, he is sitting on the shop. He's doing simple calculations. His cognitive, intellectual functions are much, much better. He didn't have any episode of seizure. I am pursuing him to get a DSA done, but he is very fearful of any new surgery, which I might tell him. I said no, but again, we are waiting for DSA just to prove our point that the surgery has worked. Cranioplasty is not new. Everybody does it. I couldn't resist the temptation to share this slide with you for two reasons. One is the shape of the skull. Obviously, this gentleman had the shape of the part of the skull removed as a part of decompressive craniectomy because of the brain hemorrhage. He recovered. The second part is the confidence on the face of this gentleman after the cranioplasty. He went into severe phase of depression. He was on antidepressants. And when this bone flap was put back in, his confidence is back. His antidepressants have almost reduced to a simple drug in the night. And he's become a very productive member of the society. Now we can do it by putting their own bone back, or biopore implants, or 3D printed titanium implants nowadays, which are easily made in our country. Futures is robotics. It is here. It is already here. It is not a future, but cranial robots and spinal robots are, yes, again, they are in infancy here. We would be getting this very soon. The ROSA is for cranial robot, for mainly used for DBS, but now stereotactic biopsies. Mesorex is by Medtronic has introduced a fantastic robot for spinal procedures. They claim that the complication rates are near zero, but again, not exactly zero. Their micro movements are avoided and the screw placement is intact. We do not injure nerve and spinal cord. So in the last, this wouldn't have been possible, and this cannot be done by a single person. It has to be a team approach. As Henry Ford has said, coming together is a beginning, keeping together is a progress, and working together is a success. I thank you all, but most of all, I thank you our patients, because there is no greater teacher than them. Thank you.
Thank you, Dr. Anurag.
Thank you.
I request Dr. Sachdeva and Dr. Bhatnagar. Dr. Bhatnagar to conclude. Dr. Bhatnagar. Thank you, sir. It was such a comprehensive talk. Dr. Sachdeva.
He has covered almost the entire spectrum of neurosurgery. It's good. I think it must be quite informative for the audience.
So,
with
thank
this,
you.
Conclude this session.
Okay, sir. Thank you, Dr. Anurag, Dr. Sachdeva, Dr. Bhatnagar. Now we'll move for the third topic. The third topic is endoscopic sleeve gastroplasty and robotic GI surgery. The speaker for the session is Dr. Randeep Vadhavan. IMA Dwarka is pleased to introduce him for his first interaction with us. He is minimal invasive bariatric surgeon in Manipal Hospital. The chairperson for this session is Dr. P.K. Gupta, one of the senior most surgical specialists of West Delhi, presently head of the department in Venkateshwar Hospital. He is one of the senior most member of IMA Dwarka. Dr. Gupta, please introduce Dr. Randeep Vadhavan. Dr. Gupta, please. Are you there, sir? Dr. P.K. Gupta, sir? Okay. So, he's not there. Okay. So Dr. Randeep Vadhavan is head of the department and consultant at Department of Minimal Access Surgery, Bariatric and Metabolic Surgery and Gastrointestinal Surgery at Manipal Hospital. He has had an illustrious career with various recognition like Honorary Secretary, OSSI, and he's a treasurer of HSI. He has delivered more than 250 lectures as invited as faculty and prestigious orations in national and international conferences. I invite Dr. Vadhavan, sir. Sir, this is first interaction with IMA Dwarka. I welcome you, sir. Thank you, sir.
Thank you very much, ma'am, and thank you very much, and thank you for inviting me here. It's a Sunday evening, and I still find a lot of people watching, so that's quite wonderful. A very good evening to all of you. Let me just see if I can you see my screen, please?
No, sir.
You can't, is it?
I can see the arrow.
Okay. So
Sir, please share the screen. You are sharing whiteboard right now.
Yeah, it's a whiteboard.
All right. So let me see, because I thought I'm doing all right by sharing this, but let me see. I'll just sort it out. Maybe I'll, yeah, so I'll just have a look. Can you see the screen now? Can you see
sir. Yes, sir. Yes, sir.
Okay. Yeah, so thank you once again for inviting me here, and a very good evening to all of you. Completely two diverse topics: endoscopic sleeve gastrectomy and role of robotics in colorectal procedures. And as we go along, I'll tell you why I chose this subject. We are a center of excellence at Manipal hospitals for obesity and metabolic, from the Obesity and Metabolic Surgery Society of India, for bariatric and metabolic surgical procedures. We know that there is a huge prevalence of obesity and diabetes in India. Globally, there would be 1.9 billion adults who are overweight, or 650 million who are obese. Approximately 2.8 million deaths are reported as a result of being overweight or obese. In India alone, we have 135 million individuals who are obese, and that prevalence of obesity is primarily also with central obesity, which obviously leads to an increased chances of coronary artery disease, hypertension, and so on. In India, non-communicable diseases account for almost 60% of all deaths, more than what is happening in COVID and so on. And 44% of disability-adjusted life years, which are lost. So a huge amount in 2011, and 2020 would not be any different. India has 69 million people with type 2 diabetes, and all you physicians there would be getting a lot of people who are being treated for type 2 diabetes. These numbers are only going to increase, and we would probably be at 140 million by 2040. So it's huge, and therefore we are known as the diabetic capital of the world. Obesity obviously never comes alone. It always comes with a lot of other comorbidities. We know diabetes, we've discussed heart diseases, high blood pressure, and lot many cancers as well. All that list is there, which is connected with obesity. So this was a paper which was published last year, and I was one of the co-authors in this paper, and this is the guidelines of which patients should be treated by bariatric or metabolic surgery as per the BMI. Now, as per the BMI, the accepted norm is that for Indian patients, BMI more than 35 with or without comorbidities, we should advise a bariatric or metabolic surgery. Anyone with 30 and above with at least 2 comorbidities, we can still advise a bariatric or a metabolic surgery. Also, we've mentioned that we've taken down 2.5 BMI points, and this has been done primarily because the Asians and particularly the Indians get diabetes and all the other comorbidities or metabolic syndrome much earlier than the Western population, and therefore we've got it down to 27.5 only, but with a caveat that non-primary treatment option for acceptable Indian patients. So non-primary, it cannot be the first line choice. First line has to be medical treatment. Not responding, one can go down with 27.5 with all the support indications. Age group, also waist circumference more than 80 centimeters in female and more than 90 centimeters in male can be considered, at least with 2 comorbidities. Age 18 to 65 by and large, but we can go down to 15 as well if you weigh that these patients will respond much better with a surgical procedure rather than being given a medical treatment. So those are by and large the indications for a bariatric procedure as of now in India. And so patients come to us, and they would go to you as well, and they come to us and they say they want cure for obesity, they want cure for diabetes. So what is our answer? Our answer is very, very clear that both these diseases are chronic diseases. We will not say we cured obesity, we cure diabetes. We can only say that we can achieve and maintain optimal weight loss or maintain sugar levels. That's all that we can say by either a metabolic surgery or a bariatric surgery. And of course, the patient requires a nutritional optimization, a commitment to regular structured exercise, increased lifestyle activity, stress management. Realistic goal setting is extremely important. Somebody who comes in at 140 and wants to get to 70, it's unrealistic. It probably will never be possible. So you need to tell them realistic goal setting and what they need to do to ensure that the best results are optimized. And for that, you obviously require a great bariatric team. Surgeon is only part of that team, only an important cog in that wheel, well supported by a coordinator, anesthesiologist, a medical fraternity, dietitian, counselor, physiotherapist, staff nurse. And we are blessed at Manipal Hospital to have all this together, and therefore our center is a center of excellence. So today I'm not going to be discussing all the other procedures. I'll just be discussing endoscopy, and that is very pertinent to the physicians as well. And I'll tell you why. Because when an obese person walks in, you generally would advise a pharmaceutical treatment. You would say that, okay, we have liraglutide available, we have orlistat available, we have diet and medication available. So let's start with those and let's see the results. Yes, the results are very minimal. The results are not as good. And therefore, these patients may not respond to the medical treatment. That's when endoscopy comes in. So not everyone wants a surgical treatment. Not everyone responds to the pharma treatment. So it kind of is in between that pharma diet and lifestyle and surgical treatment. That's where endoscopic sleeve gastrectomy comes in. Endoscopically, you can do two procedures, either a balloon or a intragastric gastroplasty. Now, balloons were put, they are still being put, but results are not very good. The compliance is not good. Balloons need to be taken out after 6 to 8 months. Patients get back their weight again. So by and large, it's a wasted exercise. That's where this endoscopic sleeve gastroplasty comes in. What we do is we put sutures to reduce the size of the stomach. By reducing the volume of the stomach, it's a restrictive procedure and it's a malabsorptive as well. And I'll tell you why. Short video. So this is an instrument which is attached to the end of the endoscope. This is the endoscope on which this is attached. And what we do is we have a suture. This is a Prolene 20 suture. Now this suture with this needle can go from one end to the other, and this is attached to the tip of the endoscope. So it's just an endoscope. Patient is under general anesthesia. It's 1-day procedure. The patient comes in the morning, gets this procedure done, and can get home the next day morning. So 1 day of hospitalization is what is required. And how we do this procedure is, you've seen that's how the needle moves, takes the suture, goes to the other end, and then you can leave the suture back behind. So by pressing of that, so we enter with the endoscope into the esophagus. So we are entering into the esophagus over here. That's the esophagus tube, so as to protect the esophagus from this needle. Once we enter the esophagus into the stomach, that's where we enter into the stomach. We identify the greater curvature of the stomach. Once we identify the greater curvature of the stomach, this is a helix. Now, helix is something which is like a screw. You push the screw into the stomach wall, pull it up, and then pass a needle all around it. Simple to understand that the needle is passed and therefore the suture is passed all around it. Once we pass this suture, then we can keep passing this suture all around and making a U shape to reduce the size of the stomach. So what we are doing here is passing the helix, pulling up the stomach, then passing the suture, just so that we can reduce the size of the stomach. So this works like a sleeve gastrectomy. It's not as powerful as a sleeve gastrectomy, and therefore it is being used in BMIs, which are actually between, let's say, 25 to 35 people who've tried their utmost to lose weight, are unable to lose weight, and therefore they come back and they say, okay, doc, we want something which can be done. We still don't want a surgical procedure. We want something which is less invasive and, 1 day stay. We don't want any cuts on the abdomen. So this is when this procedure comes in. Reducing the size of the stomach. What happens is, once you reduce the size of the stomach, it's a metabolic procedure as well. How it is metabolic? Because what happens is it increases decreases the gastric emptying time. So the stomach empties faster. Once it empties faster and reaches the distal ileum faster, there is increase in the secretion of hormones like peptide hormones like GLP-1 and PYY, and therefore it is a metabolic procedure as well. Helps controlling diabetes, NAFLD, particularly fatty liver disease, hypertension, and so on. So it acts both as a bariatric procedure and as a metabolic. We are not comparing it with a bariatric, not with a proper surgical procedure. We are only saying it's in between that period of 25 to 35. Young girls who want to get married, young boys who want to get married, they've tried exercise, they've tried all other method, doesn't work. This is a fine method by which you can actually lose not large amounts, but 15 to 20 kgs, and then you can by and large maintain it. How you maintain it? These sutures tend to fall off. They will fall off in a period of 3 to 4 months, but with the fibrosis, the stomach just stays there. Once it stays there, the shape of the stomach is maintained, and you can actually maintain that weight. So this was a paper which was published just about 6 months back, comparing it with sleeve gastrectomy, and they found that obviously the sleeve gastrectomy does a lot better. There are no side effects of endoscopic sleeve, but then again, what it does is it gives a reasonable total weight loss, and so like a bridge between the pharma treatment, diet and lifestyle, and bariatric procedures. It's in between those and gives excellent results. We do all kinds of bariatric procedures. We do all kinds of bypasses. We do reversals, back to normal anatomy as well. But I found that this procedure, not many centers around in the world in India are doing it, probably 5 to 7 centers, because you require a special endoscope and all the equipment. We at Manipal have that. And so I would say it forms like a current evidence indicates that ESG offers satisfactory efficacy in weight loss, even if it's inferior to a laparoscopic sleeve, lower incidence of adverse side effects as compared to a balloon or any other procedure, ideal weight control strategy for patients who have poor adherence to behavioral interventions. Gut hormones are released, and therefore it can also be called as a metabolic procedure. So that's where the endoscopic sleeve comes in. Moving on to the next bit, the robotic procedures. Dr. Mishra sir, in fact, went through beautifully in what is done in cardiac. He's one of the pioneers of cardiac robotic procedures. We have moved on to do a lot of procedures by robotic surgery. Shorter recovery time, length of hospital stay is less, aesthetically a lot better, less stress on the surgeon. So surgeon also is the most important, a patient is the most important factor, followed by the surgeon. Now, if surgeon is important, less stress on the surgeon, ergonomically excellent, and we'll see why. Ergonomically, it's a lot better. See, you're sitting down and then operating. You don't need to be standing. Even in laparoscopic surgery, I have to keep standing and I have to keep operating. And during that process, 6 to 7 surgeries in a day, the back starts to pain. You're just sitting down and operating. You, of course, require certification to be using the robot. We have all those certifications in place. Just a short video of what it looks like. This is the Da Vinci robot, and Dr. Mishra sir has already mentioned it. This is how it moves. The arms moves. That's the patient cart. That's the patient cart which moves in all direction. That moves. This is the surgeon console. The surgeon sits on the console and sees in 3D, and then operates. That's the master key. So the surgeon basically is operating on a thumb and the index finger. So thumb and the index finger or the middle finger, those are the only two things which you work on, nothing else. Surgeon is sitting very comfortably and operating, watching on a 3D screen. Everything is actually 3D, and you can suture like, all those patients who would come to your clinic and you would suture on the skin. It's like sitting inside the abdomen and operating. So it's that great. You can actually feel, because it's a 3D, so you feel you're sitting inside the abdomen and operating. Very simple to use, and excellent ergonomics. And you can actually do 7, 8, 10 procedures without any issues. Next question, almost always the patient asks, if the robot is operating, what are you doing, doc? Do we really need to? So the answer is, I'm controlling the robot. Robot doesn't operate by itself. It's the surgeon who actually controls the robot. Pros of a robotic surgery: it magnifies, refines instrumentation to achieve exposure retraction, reduces reliance on second experience assistant, because the camera, the instruments, everything is under your control. You only require one assistant and no more. Equipments are very flexible at the wrist. It's a 3D vision that you get. Superior ergonomics, multiple movements are possible. Of course, there is a higher cost attached to it. You need to have larger volumes to be cost effective, and therefore you require multiple teams to be operating: urology, myself, cardiac surgery, gynae, oncology. So there are multiple teams who operate, and therefore the costs are covered. Longer duration, because you require to be having the docking of the robot and undocking, but by and large, with time, that also reduces. Difference between laparoscopy and robotic: again, dexterity is a lot better with a robotic. It's a skill-based error reduced to 93%, because you require lesser skills for a robotic surgery, more for a laparoscopic surgery, in fact. Time needed to complete the task is shortened by about 40%. 3D vision, of course, these days we have endovisions which are 3D, but this is fantastic. Like I said, sitting inside the abdomen, 7 degrees of movement are there, which a human being, even a laparoscope can give you only 4. Laparoscopy has a steeper learning curve. I've done 30,000 laparoscopies. I know there's a steep learning curve. I moved on from doing laparoscopic gallbladders to doing the most advanced laparoscopy, which is possible these days. It has a steep learning curve. Relatively, the robotic surgery has a much lesser learning curve. We do all these procedures. I'll stick to a short video of a robotic colorectal, and I'll tell you why. We do Heller's cardiomyotomy, paraesophageal hernias, the bypasses, bariatric procedures, esophagectomies, pancreatic resections, and so on. But robotic colorectal, particularly because approaching the pelvis is very easy. There is a superiority of the robotic surgery, particularly if you're approaching the narrow areas. Surgeon can control the stable camera, delivering magnified full HD and 3D imaging. Robotic system manipulates the instrument. There are no tremors. So remember, I may not have tremors, but some surgeons do tend to have tremors with time, and this eliminates that as well. So the tremors of the surgeon is not translated onto the patient. So that's fantastic. Flip side is there's no haptic sensation. You cannot feel the instruments. Even in laparoscopy, you can feel the tissues. Here you cannot feel the tissues. But by and large, with experience, you can eliminate that part. A surgeon basically operates with a camera and the foot paddles like driving a car and sitting inside the car and then driving it. This is an excellent data which was published. Now, this data, it's a very complicated kind of slide. I'll just make it easy for you. It basically tells you this was a comparison between laparoscopy and robotic. First 30 cases, they found that laparoscopy was faster as compared to robotics. Next 30 to 60, they found that laparoscopy and robotics were by and large equal. Beyond 60 procedures, they found that robotic was faster, gives you better results, better outcomes, lesser blood supply, early discharge, and all the advantages. So just suggesting that once you gain experience, the robotic surgery offers a lot better. And a short video. This is a patient with a rectal cancer. It's a middle third. We are doing a low anterior resection. Those are the ports. That's the robot which is docked. This is how we go in. Those are the robotic instruments. And we are making a dissection. Very simple to do. You know, you are seeing 2D. I would see this 3D. So like I would be, like I said, sitting inside the abdomen, just operating, making these small incisions, very easy, bloodless completely. The other thing is in all these colorectal procedures, what would happen is you would see these nerves. You would have heard about hypogastric nerves, nervia urgentis, and all these nerves, which actually are responsible for our urinary issues as well as ejaculatory issues and so on. So you prevent those nerves, and as a result, these patients in the post-operative period would have less of problems regarding their urinary issues, regarding their infertility issues, and all the other problems. This is a lymph node which is being harvested. So you can save all these nerves, and the patients, the compliance is a lot better. Patients are a lot more happier. You at best can have a bit of neuropraxia, which generally goes away in 3 weeks. So you would have less of these nerve damages because you can see them much better. And also you can take the blood vessels right at the origin, because it's much easier to dissect them and take them right at the origin. Then again, you're dissecting in the pelvis, two important structures, right and the left. Ureters are there. You can see them well, ensure that there is no damage to those, and take the vessels right at the base. So this was a patient of CA at the middle third of the rectum. We can go right down to the pelvis. Once we go down to the pelvis, what we can do is we can fire a stapler. We can fire a stapler there. Once we can fire a stapler, then for the anastomosis, again we
kindly mute your speaker, please.
Somebody has to mute themselves. Yeah. Thank you. So then you can fire a stapler, and then you can do the anastomosis. So these anastomoses are again done by staplers. Those staplers are of course used by one port which the assistant is using, and then look for any leak. If there's no leak, you're fine. So what does just put in a drain and come out, and you don't require stomas. So the stomas, colostomy, the temporary colostomies are also minimized, though of course at times when it is required, patient has received new adjuvant radio chemo, you will require a temporary ileostomy, but by and large in these cases it's sort of eliminated. 5 studies suggested that surgical devices, this was published just about few years back, that robotic procedures were more expensive than laparoscopic because there is a cost attached to the robotic instruments, increased length of operative time, post-operative, maybe ICU stay, which is again minimized with experience. Hospitalization is minimized, but there is an initial purchase fee and yearly maintenance fees. But then Higgins et al. Did the study that robotic surgery can be cost effective because of reduction of costly anastomotic complications. With laparoscopy and others, there are more evidence of or more incidence of having anastomotic complications, more blood loss, which can be minimized. So in a long run, probably the robotic surgery would be cheaper and then again giving much better results because the outcome, long-term outcomes may be a lot better. Presently, the data says is almost the long-term outcomes, 5-year survivals is almost similar. The early benefits with robotic surgery are definitely there. So in conclusions, friends, compared to a traditional surgery, robotic surgery provides a surgeon with greater range of motion and precision, which may lead to less bleeding, less post-operative pain. Both patients and surgeons benefit from more advanced surgical robots because the surgeon is sitting down ergonomically a lot better. Patients are expected to see better outcomes and quicker recovery times, while surgeons will enjoy devices with increased dexterity and more compatible instruments. Robotic surgery will reduce conversions to open surgery and is associated with shorter length of stay, much less blood supply, early return to work, early discharge from the hospital, and maybe at the end of the day, lesser costs as well. With that, friends, I conclude my session and thank you very much once again for inviting me and having this interaction with you on a Sunday evening. Thank you very much.
Thank you, Dr. Vadvan, sir. Dr. Gupta, can you connect, sir? Okay, then I'll invite Dr. Chaurasia to conclude the session.
I am audible?
Yeah.
Yes, you are, sir.
Dr. Randeep Vadhavan, he has presented very comprehensive as well as elaborate presentation. And he has, I think, not left anything about minimally invasive as well as robotic surgeries. So it was very excellent presentation by Dr. Randeep. I think Manipal has so the best team for minimal invasive as well as robotic surgeries in all the field, cardiac, neurosurgery, as well as the bariatric surgery. We are very proud that we are in the vicinity of Manipal.
Thank you, Dr. Chaurasia. Thank you, Dr. Vadvan, sir.
Thank you, ma'am, and thank you for inviting me.
I hope in future IMA Dwarka will be having more interactions with you, sir. So,
thank you very much, ma'am.
Thank you, Dr. Chaurasia, Dr. Gupta, and Dr. Vadvan, sir. So now is the turn of most awaited lecture of the day by one of the most eminent medico-social activists, Vice President of DMC, and past President of IMA DNZ. The topic is challenges faced by family physician in today's India. The chairperson for this session is Dr. Kiran Shankar Banerjee. Dr. Banerjee is one of the senior most member of IMA Dwarka. He's the past president of IMA Dwarka, senior pediatrician, West Delhi. So I invite Dr. Banerjee to introduce Dr. Naresh Chawla, sir. Thank you, sir.
Good evening, everyone. First of all, I thank Dr. Deepmala for introducing me as chairperson. And I welcome Dr. Naresh Chawla, who I have a great association with him for a long time, being in DMA. Dr. Chawla is Vice President of Delhi Medical Council, and he was Vice President, he was President of IMA, and IMA DMA, and President of IMA North Zone. and he is a family medical consultant for 38 years and practicing at Pitampura. He is a medical social activist and long known for his comments on the position of society and the medical field. Mainly we often see in the newspapers. Thank you, Dr. Chawla. And he is not only a doctor, but he is also a great blood donor. And he has already donated blood for 136 times. My God. Still, you are looking very healthy. And I pray to God you remain healthy forever. And I welcome Dr. Chawla. Please continue your lecture. Thank you.
Dr. Chawla, sir. So, Dr. Chawla, are you connected with us?
Amit, I think Dr. Naresh Chawla has lost connection. Can you kindly upgrade him? If he is in the delegate list, can you upgrade him?
Okay, sir.
Upgrade him and give him the admin rights.
Access to switch on audio.
सर प्रमोट कर दिया.
I think Dr. Chawla is there now.
Am I audible, Madam Ankur? Am I audible?
Yes,
Am
sir.
I audible
Yes,
now, madam?
Yes, sir.
Very
You are
much,
here.
sir.
Sure, sure.
Good evening, sir.
Good evening, dear colleagues. First of all, I thank IMA Dwarka for giving me this opportunity to share my views on one of the biggest resources among the medical personnel, which in my personal opinion is very, very little utilized. So a word about IMA Dwarka first. IMA Dwarka is one of the youngest branches of DMA and perhaps doing a huge role in disseminating information, whether it is CMEs, doing other roles, whether it is socio-medical or it is cultural. I have seen them doing very, very well. I'll congratulate a bunch of enthusiastic workers of IMA Dwarka, which includes the president, Dr. Mukesh, the secretary, Dr. Pankaj, past president, Dr. Prakash, also, who is the senior VP of DMA, and Madam Dr. Deepmala Lalchandani. I'll congratulate this couple also, how remaining in the same home, they are working so nicely and uplifting not only their branch, but practically whole of DMA. Congrats to all of you. Now coming to what I like to speak the most, and I'm doing this role as a family medicine activist for almost 3 to 4 decades. The moot point is that GPs or family physicians or family medicine activists, they constitute practically 60 to 70% of the whole medical population of perhaps whole of India. But are they able to assert? Are they able to make a place for themselves? Are they able to contribute in India's healthcare? Are they able to maximally utilize their energies? So my answer is perhaps not. So today for next few minutes, maybe 15-20, I'll be taking less time than my learned super specialists who have gone out of the way. Before I started speaking about the role of a family physician, I must say kudos to the super specialists of India who have made a place for themselves in all across the world. And India is perhaps the best medical tourist nation in all the world. Sometime back, when there was a question of granting visa to only 2 weeks back, India permitted the foreigners to come to India for medical tourism. So when I speak, when I glorify the role of a general practitioner or a family physician or a family medicine specialist, I never mean to undermine the role of the tertiary medical care and the super specialist and specialist and subspecialist. They are doing a tremendous role. But this is where the flaw lies. Somewhere there down the line, there's lack of coordination and the optimum utilization of the services of a super specialist and a GP is not done. And in next few minutes, I would like to bring to all the people who are on this Zoom to know how best we can do it. And we must do it fast. India is suffering, India is bleeding, India is nowhere near in the first 100 most healthy nations of the world. Why is it not? India is the biggest democracy. We have a big economy. We are called a big nation. We are called a growing economy. We are practically the biggest democracy. But why not our healthcare? And on the top of it, our skilled medical manpower is appreciated all across the globe. Where Indians are, whether they are general practitioners or they are specialists, they are always known and appreciated for their medical skills. Now coming to my actual presentation, step by step, where the flaws lies and how best we can invigorate the family physicians or the general practitioners, how to make better of them, how to make best of them, and how can it benefit the medical care in India. The challenges faced by a family physician in today's India. I already said when they constitute a big chunk, we have seen in all the Western world, in Europe, in America, in Australia, any part of the world, even the neighboring big nation, China also. There is a huge role of a general practitioner. He is at the beginning of any medical order. But in India, unfortunately, it is free for all. I have seen a cardiologist, busy cardiologist, writing a prescription for a fever indication in a cardiac patient. Why can't the same thing be done by a general practitioner? Why can't the same thing can be done by a family physician? So the health scenario in India, in a large and growing country like India, with limited resources, will always be ridden with pressures on finances, resources, and logistics. With the advancement in technology, there will always be a conflict between using expensive newer technologies and cost-effective, well-proven methodologies in clinical practice. Let me remind you, ever since the coming of Corona and all across the world has realized that the newer technologies and the higher technologies apart, when it comes to the care of the patient, the primary healthcare plays a huge role. 70 years after independence, is India a health sufficient nation? In fact, India is nowhere near even below 100 rank among healthy nations. Why so? Why so? When Indians claim to be intellectuals, we are intellectuals, we are better than practically most of the world, then why are we lagging behind? Because of many factors, primarily two things, which has been said dozens of times, thousands of times, millions of times: poor emphasis on education and primary healthcare. Why do I glorify a family physician? Why do I glorify a general medical practitioner? A general practitioner, the all-purpose, amiable neighboring doctor who is engaged in providing primary health care, first contact care to all members of a family, irrespective of age, sex, system, and diagnosis. Think of most of us, the people who might be listening to me, must be among 30 to 40 to 50 to 60, 70 years. Imagine, didn't we always have a family doctor? Didn't we always have a person who listens to everything? We used to go to him first. But ever since the advent of specialties and easily availability of specialties, people have started rushing to the specialist straight down as the first choice, which is the most wrong thing, which is an improper utilization of our health of medical resources. I know of people who had a very little problem. I wouldn't say got trapped, but got rather wrongly sent to a specialist or whatever, and unnecessarily spent more money, spent more time, spent more energies, and ultimately diagnosis could easily have been made at the primary healthcare level, that is the general practitioner or a family physician. So my question is, when we have everything, we have manpower, we have the will, do we blame the system alone? I will not. It is a bad habit of us Indians to blame on the system for everything what goes wrong. I always say, system is nothing, but it is us. System is nothing, but it is me. System is nothing, but system is you. So each one of us, when I'm addressing my family physician friends and even consultants and specialists also, they also have a role to play in upgradation of a general practitioner. They also have a role to play in giving all the respect and dignity to the general practitioner and a family physician so that a proper coordination occurs and patient gets the best of medical care at most economical rates. As we always say, government is wrong, system is wrong. So government say we will ask the government and the health planners and the community leaders and the medical leadership also. Why not our voluntary medical leaders? Why is not the effective utilization of resources being done? I clearly remember when I was the president of Delhi Medical Association in 2009-10, I was under huge pressure to tell all the members of Delhi Medical Association that these are our rates, these are our services, whether it is a general practitioner or a specialist or a super specialist. But we could never attain a unanimity in this. The issue fizzled out, so it remains in crisis, in limbo, as bad as it could have been. You would think, why should India not progress? Why is Dr. Naresh Chawla harping on the old GP or the family physician when India has made tremendous progress in tertiary medical care? Which is no doubt the tertiary medical care is no doubt at most required, but it should occupy only, I would say, 10 to 20%. Most of the jobs, most of the medical conditions can be tackled by at a primary care level only. Sometimes I have seen the the tertiary care super specialists do not get the kind of work they which they are able to do. A GP, as I already used the word, a general practitioner who is at the grassroots level of all medical and healthcare is the most, I'm extremely sorry to use this word, perhaps my other colleagues will agree, is the most maligned and unhonored of all subgroups of medical fraternity. Is he a victim of his own making and now struggling for mere survival in this unorganized spectrum of medical hierarchy? I always ask this question whenever I am asked to speak. Is general practitioner, is a family physician a dying tribe? It is not, and it better not. And if it is dying, then we all medical practitioners, whether it is GP or specialist or super specialist, we have all the reasons to resuscitate and revive this tribe and give him the pride of the place. Already said the same words, slightly undignified. First contact with other practitioners. This is where the role of other practitioners come to the play. With the other practitioners refusing to acknowledge the most demanding and useful role of a general practitioner and cooperating for the better patient care. Now, as we all know, we are facing a corona crisis. Even in Delhi, whether it is private medical ward or it is government medical ward, you would agree with me, practically 80 to 90% patients are landing before a GP only. Now ask yourself this question: which patient to retain with him, which patient to get COVID-19 tested, which patient after seeing his SpO2 immediately be referred to a tertiary care hospital, is a most difficult job. A general practitioner or a family physician does add this with his medical skills only, with least of investigations, least of tantrums, at most economical rates, and in most comprehensive manner, and in a manner where he satisfies all his families. As you all know, it is not a running medical practices these days. We all general practitioners or family physicians have well-defined families. Say someone is having 500 families, someone is having 1,000 families, and we are answerable to them. So after we receive a patient, we have to give an answer to the patient. Yes, Mr. Patient, you are bad enough. You immediately shift the patient to a tertiary care hospital. Nice, no patient. Your symptoms are very well there. Who could be confusing or ambiguous symptoms, so we can observe for a day or two. So you would all agree with me, a family physician has a very difficult role. A patient landing in a major hospital has access to all the investigations, access to all other medical opinions, but in a single doctor clinics, which most general practitioners and family physicians are owning. And I would say, I'm proud to say, these days even many MD medicines also and other people are also have formed single doctor clinics, and they are doing fairly good work. Everybody and anybody who is concerned or is conversant with the healthcare delivery system of India agrees that general practitioner is the soul of health services. But for years together, the systems need to be streamlined to provide the GP a much needed place of pride. I clearly remember having a patient in London. Once he was someone advised him get an MRI done. The system is so strong till the time the general practitioner there, the GP, who is the most learned and most honored person there, does not prescribe. Even a specialist or a hospital will not carry on an investigation. Same is the system in the United States of America. Same is the system in whole of Europe. Same is the system in Australia. But good damn India, I am extremely sorry to say, it is a free for all. The government may not facilitate all this, but why should all of us, be instrumental in making a system whereby this may happen? A family physician is a vital link. Unarguably, family physician de facto and will remain the mainstay of medical care to society, but the vested interest will try to undermine the credibility and morale of these pillars of healthcare delivery system. The existing practicing family physicians are duty bound to uphold the pride of this class. I'm reminded of a old story, which is not only a story, which is a fact. Is a well-known fact. A businessman, I'll tell you, it's a story only. You will say a businessman started having a dizziness kind of a problem. So everyone, he was around 50 plus or something, maybe was a diabetic, was an hypertensive, otherwise well settled. When he goes to his physician first, he goes to who refers him to a neurologist, who refers him to a cardiologist, who refers him to a physiotherapist. Ultimately, he goes back to his general practitioner or his family physician, whom we knew years back but had lost the contact. The family physician listens to all the stories and comes to know that the person has had an income tax rate some time back. It is the soothing few words of the family physician who could understand when every investigation, it is MRIs or EEGs or echocardiograms, everything is normal, patient is otherwise visibly well. He used only two words. कहता है लाला जी आपको तो बहुत खुश होना चाहिए कि आपके घर इनकम टैक्स ने रेट डाली है, आपकी तो इज्जत और बढ़ गई. It is not only a story, it is a fact, and the patient was well thereafter. So I always rank the psychosocial role, of a family physician. It is so very important. Our house ladies, our ladies who form a huge chunk of everyday OPDs, I would say not 100%, but 70 to 80 to 90% patients are merely psychosocial patients, presenting with nothing but it is dizziness, chakkar, ghabrat, etc., etc. So we all are aware of it. Who can be treated by very little treatment without any major expensive investigations? Why not do it? Why? It's not that all patients are without any major illness, but I would say vast majority are. So this is where the role of a family physician who knows the role. I always remember one thing. If you know a family, and if you are a family physician of a family, you are not only a physician or a doctor, you are a family member. I think a mere just 2 minutes talk with the family will practically give us almost 90 to 98% of diagnosis. Few will need expensive investigations. Now, I have said the problem, the how to get out of it, why and how to reinvigorate the important link in healthcare delivery system, the family physicians. And even if the general practice is diminishing, we know very well these days, under the glamour of specialization and super specialization, there is somehow feeling that GP is a lesser doctor. I think we all are duty bound to uphold the dignity of honor of this class when the developed world, including the United States of America and Europe can do it, Australia can do it. Why can't India do it? Why should India suffer under the burden of only tertiary care only and the GPs practically fading away? Sometime back, since I practice in Pitampura, North Delhi, so I have seen one thing. In last 2 decades, there is hardly any new family physician who has added. So what does it mean? Is this class diminishing? We rather not let it diminish. We need to strengthen these general practitioners. We are the ones, whether it is a cancer patient, whether it is a surgery by a neurosurgeon, whether it is surgery by a cardiac surgeon, these are the very people who are required for a follow-up, for the domiciliary care of all these category of patients and many others. I remember many patients having returned from their treatment from a tertiary hospital. And then they say, doctor, the doctor has declared me that I need not come to the hospital. Now I better be taking nursing care at home only. Who will do it? It is a trained family physician who has been specially trained to do it. There is a lot of flaw in our medical education. I'll come a little later on how best we can equip a family physician or a general practitioner or a primary care physician with more knowledge, more training, so that he can do his role more effectively. It is not only he can do it, it is not only he can do it, but he should do it. This is what is most required, is my appeal to my general practitioner when I say from the rooftop that they need to do a better role. They need to be better equipped also. They need to have better training also, but also they better learn to take up the challenges. They do not have to be happy with their simple general practice. They have to go beyond. So in the larger interest of, there's a need to resuscitate and revive the family physicians. I'll go back. After graduation from any medical college, the successful candidates try to go for higher education, and 30-40% are able to garner postgraduate seats. What happens to the rest? They opt for government sector jobs, either through UPSC, SSC, PSC, ESI, etc., etc. And the rest are, I should not use the word forced, but by the situation, by the circumstances, go for opening their own single doctor clinics. But I'm proud to say Delhi alone is host to thousands of doctors who have their single doctor clinics, who are success stories, who have made a huge challenge to this kind of practice. They are financially much better off, they are professionally much better off, and they are a tribe which any city can be proud of. And the better still, they are doing a huge service to the society. As already said, they are forced by circumstances to enter general medical practice. So this is where the flaw in medical education lies. I am proud to say that National Medical Commission, which has taken over from MCI only recently, they have announced a huge specialty of family medicine, and now they are giving family medicine all the pride and all what has not been done in last 7 decades after independence. So it is this class of people who need to be trained either as a part of undergraduate curriculum or even after graduation or even after in practice also. They need to be trained so that they can optimally and maximally utilize their energies for better, I would say, delivery of medical services. Why has such a situation? As we all know, India is struggling ever since for last 7 decades after independence, where our emphasis has been largely on either defense, not that is not required, but education and health are two areas with hardly 1 to 2% of the budgetary, the central government's budget. What can you expect? Health was never a priority, never a priority. You must have seen how unpopular medical profession has become with all those assaults, all those problems and hindrances created by civil administration, all those the charges. Sometimes it is medical wastage, other times it's solid wastage. So everything make the life of a doctor difficult. So because of politicians and health planners lack of priority and planning, despite being the biggest required thing, the health has suffered hell of a lot. And the worst still is that we do not see much. Governments have kept changing, new parties have come to the power, but none has ever realized that, as already said, if you want a nation to progress, it is the education and health we have to be given uppermost priority, which is not being given. I don't know what is going to happen tomorrow, but we as a pressure group, we as a I would say lobby, we must see that we get our rights. We doctors alone, our medical manpower alone, we are almost more than 5 lakhs. But we are not only 5 lakhs. Each person has at least 100 to 1,000 committed people who would agree with us. We are a huge force. So we must bend the governments. We must be a pressure law. So since the budget is limited, all the funds it has taken all the for the tertiary care, and huge commercialization has taken place. The corporate culture, which I believe not that is not required, but it has taken over. There should be a proper symbiosis between the corporates, the government hospitals, the standalone clinics. That's what we require. So what is happening is a free for all. Whatever is happening, we are not able to stop. This is where the role of our medical associations and medical council comes. We have to create a lobby, and we have to
Amit?
Yeah. I think there's some but I'm getting it sorted out. Dr. Deepmala, is my voice clear? The slide has come back, Dr. Deepmala?
Sir, your voice is clear, but
slides are coming or not?
Slides are not coming.
But I think by the person who is helping me says it has come. It will come.
Yeah, Amit, kindly speak to him.
Yes, ma'am, just a moment. Ma'am, sir hasn't shared his video till now. That's why we can't see.
Okay. So your videos are not shared. So your videos are not shared.
Amit, Dr. Chawla has.
Is it has it come now?
Left.
Yeah.
Yeah, it's visible, sir.
Dr. Deepmala, has it come now?
Yeah, yes, sir. This.
Chalo. So the main thing, the challenges being faced by family physicians. So why is the general practice down? The faulty decisions of government have pushed GPs to the stage general practices was a popular vocation among doctors. So this is the reason. I remember still, you go to any part of Europe and America, they will be proud to call themselves a general practitioner or a family physician. But as you all know, due to various factors, the things have gone down. So I'll be in next few minutes telling you how a general practitioner or a family physician can upgrade himself, can become an enlightened general practitioner, can enter more education even many years after having started his medical practice. So as I already have my woes that how many fresh medical graduates are opting to become general practitioners. Why is general practice so de-glamorized? The word to be used is why is it so de-glamorized? We all are duty bound to uphold the dignity of a general practitioner. Why are GPs so demoralized when their subgroup is practically 2/3 of all doctors' population? Is a huge wastage of human resource. Is a huge wastage of medical talent. They need to be trained in general practice or family medicine. If a systematic training is provided, we would have more graduates opting for general practice. Just going out of the way, there are many choices available. I'm myself a DNB in family medicine. So starting from DNB in family medicine, which any graduate can take up. It is a diploma in family medicine is also available, and there's a huge number of courses which are being provided by Indian Medical Association, and they are being provided by even the diplomat, even the National Board of Examinations. So lots of CMEs are available, lots of sub courses and all kinds of courses, be it cardiology or diabetology or dermatology, are available. The only thing is we have to provide our general practitioner friends fresh choices so that they can take the challenge and become a better and upgraded practitioner. For my knowledge, I have just an analysis of a GP's or family physician's mind. A general practitioner have become a prisoner of his own image. So I think my appeal may be more to my general practitioner friends. Worse still, the family physician today is not at times updative, assertive, and usually not forthcoming. So these three words, which are the most essential, he has to update himself. He has to assert himself to be dignified. And last and most important, nobody will feed you, Mr. General Practitioner, Mr. Family Physician. You alone have to come forward. They need not feel inferior to anyone, but just do your task more sincerely and judiciously. I am proud to say, since I am in practice in Delhi for last 37 years, people are forthcoming. People still like to go to their family physician, but he has to be a storehouse of knowledge and up to date in every such knowledge. He has to function like a mini multi-specialist. And if he does it, he is an asset to the patient, he is an asset to the family, and he is an asset to the medical profession, and he is an asset for the whole society, and he is an asset for the whole of India.
Thank you so much, sir.
I will take only 2 minutes more, madam. Just 2 minutes more. The word of our general practitioner is the need of the millennium, in spite and despite of all technical revolution and advent of specialties, super specialties, and subspecialties. A general practitioner is the first doctor in any medical locality, even in the developed Western world. The word over GIF still is a well-defined entity with a role, but not by any chance any less than any one of the other sections of fraternity. It should never be a general practitioner. Is a very important word. It should never be a GP versus a specialist. Never be, and it should be as is being depicted in our country. It should always be a symbiosis. Collective measures create a department of general practice family medicine in all medical colleges by a statutory ordinance. Create family medicine as an undergraduate subject. Introduce a postgraduate course MD in family medicine and increase the seats of DMD family medicine. Compulsory continuing CMEs for all GPs. Promotion of general practice in day-to-day government programs, upgradation and employment of GPs in medical hierarchy. A system stepwise referral to be evolved, whereby all patients must consult a GP first and a genuine and a responsible referral to a specialist coming as a second step. Upgradation, I already used the same words, I'll just cut it short. GPs can catalyze, this is the most important word I want to say. GPs can catalyze the health services. And most important, the quackery is a big problem. Quackery is a big problem in DMC, also quackery in all across India. So we can fight out and weed out a quack by proper and a proper coordination among a generalist, that is a family physician, and a specialist. And for effective health review system, we have to have a network of dedicated and lateral general practitioners all across India. Dream of a GP, I already said, he has to be upgraded and he has to claim and he has to train himself for this claim. Appeal to all GPs, you're the biggest subgroup, you need to evolve, you need to be updated in medical knowledge, and you have to upgrade yourself. Same words, a physician is obligated to consider more than disease, organ, more than even the whole man. He must view the man in his word. This is most important. In the larger industrial community, the general practitioners have to come forward and lead the new and visioned health order. Good doctors understand responsibility better than privilege and practice accountability better than business. We are physicians is a proud title. We carry prerogatives, it carries privileges. Most of all, it carries accountability also, not only for the future great profession, but the whole life of the very lives of all fellow sufferers from the human condition. Thank you very much. I thank IMA Dwarka for giving this opportunity. I had much more to speak, but the time constraint was restricted me. Thank you very much once all over again.
Thank you so much, sir. I agree, sir, that it should be always symbiosis. I invite again Dr. Banerjee, sir. Will you like to conclude, sir?
Dr. Chawla, I think very good evening and welcome to IMA Dwarka. It was a very nice talk. Very rightly you said it was not only the earliest link, but it is a vital link between the patient and the doctors, and they have a great role. And I fully endorse your views, and thank you again very much.
Thank you, Dr. Banerjee, sir. Dr. Chawla, IMA Dwarka is indeed honored to have you today, and we have lots of expectation from your side because you are a vice president of DMC, sir. So hope कि आप हमेशा IMA Dwarka को support करते रहेंगे, sir. Hello, Dr. Chawla is there?
Yeah, okay. Yeah, I'm able there.
So, sir, तो बहुत सारी expectations हैं आपके सामने हमारी, sir. Thank you so much, sir.
Yeah. Always there to guide you. My other role, which I am seeing forward, is as a DMC vice president. Also, I am not going to be lying down. I will be acting as an activist vice president, and I'll seek the inputs from all of you to make a better medical order in Delhi. Thank you.
Thank you so much, sir. So before concluding, I just want to say that now time to vote of thanks from Dr. Mukesh, President of IMA Dwarka. लेकिन just एक line कहना चाहूँगी कि please take care of yourself, your nears and dears, and the special care of senior doctors. Please get connected to them. और यही टाइम है, एक दूसरे को फोन करते रहिए, हालचाल पूछते रहिए. बस मेरी आपसे यही सबकी विनती है. So thank you so much, Dr. Mukesh, for vote of thanks. Dr. Mukesh, are you there?
Unmute Mukesh.
Yeah.
Dr. Mukesh.
Sir, it is in, am I audible?
Yes.
Yes.
It is indeed a privilege to give vote of thanks where luminaries like Dr. Yugal Mishra are present. Thank you, Dr. Yugal Mishra, Dr. Anurag Saxena, Dr. Wadhwan. I also thank all the esteemed leaders, chairpersons of the today's scientific session. Special thanks to Dr. Arun Gupta, President DMC, who spared time, Dr. Naresh Chawla, Vice President, Delhi Medical Council. And no academic programs are happen just because after there, but we need to have sponsorships, we need to have associations. So I especially thank Manipal Hospital, जिनकी एसोसिएशन में आज ये academic webinar हुआ है. Manipal Hospital has always supported our Manipal Hospital has always supported our endeavors and academic programs. Thank you, Manipal Hospital, for today's program. I must thank Dr. Deepmala Lalchandani for moderating today's webinar. She has done wonderfully. Thank you, Dr. Deepmala. And last, I will thank all the delegates who have spared time from their Sunday schedule to attend this webinar. Looking forward for your presence in our future academic weekly programs also, and looking forward for your association in our annual conference, which is going to happen in the first half of January. So thank you, everyone. Take care of self. Wishing you health and happiness always. Thank you, everyone. Thank you, sir.
Thank you, Mukesh. Thanks, madam.
Thank
Dr.
you.
Pavla, thank you.
Thank you. Good evening.
Anurag, thanks. Thank
Thank
you.
you, sir. Thank you.
Thanks, Dr. Pankaj. Thank you. Thank you hosting Manipal. We are
Thank you, sir.
Thanks. Thank you. Bye-bye.
Bless, sir. Bless.